our afternoon sessions are starting with me now talking a bit about the work that Find actually does and some of our, some introduction to some of our priorities. As a prelude to the high-level ministerial session that will start in about 30 minutes, I think the discussion about what Find does, especially for members of the audience who may not be so familiar with what we do, is an important foundation required to perhaps provide the context that you need ahead of the high level session. So, very quickly, next slide, please. So, what you may not know is that this week is actually Find's birthday because at the at a WHA like this in 2003, Find was set up. WHA 56, it's WHA 78 this time, so that tells you how old Find is. Was set up as a collaborative effort between the TDR and the Gates Foundation. And the timeline shows that, so that was in Geneva. So timeline shows that we, a few years later, opened our India office, which was sort of our largest country operation Geneva. So the Indian government was a pioneer or quickly took up or recognized the potential that Find represented. And then, as the timeline shows, we then subsequently opened offices in South Africa, in Vietnam. And then you can see sort of the formal recognition of Find's collaboration status at different times with the WHO. So first of all, for TB specifically, and then expanding in 2018 more largely to laboratory strengthening in general and diagnostic technology evaluation. Next slide, please. In 2020, which is, of course, during the pandemic, Find became even more prominent, just as there's increased recognition for the role of diagnostics and the importance of diagnostics, perhaps for the first time, achieved the appropriate political commitments. And then we then were co-leads of the Act A accelerator for access to COVID tools. Of course, this was co-convened with the Global Fund and many other partners listed there. A year later, we had the Lancet Commission on Diagnostics. Their report was published, and as part of the report at the time, it suggested that almost half of the world's population did not have access to essential diagnostics. So we were managing people in the blind. I'm not sure how many of us do that even with our electronic devices or with less sensitive issues? But the idea that only 47% of the world lacked access to essential diagnostics, and we allowed that to continue without an appropriate response still baffles me. I don't think that we ever had the kind of response that we should have had to that finding. In addition, 2021, through the G7 launched the 100 Days Mission in partnership with CEPI. For those who are not familiar with the 100 Days Mission, this mission has the sole objective of ensuring that, when we have the next pandemic, we would be able to develop the appropriate tools to respond to it. So drugs, therapeutics, and vaccines within 100 days of the pandemic being declared. It's very aspirational. We are responsible or play a prominent role in the diagnostics pillar of that plan. But what it doesn't show, which we need to pay a lot of attention to, is that it assumes that a lot will have happened before the 100 days, because you don't wake up one day and be able to make diagnostics and make therapeutics for a new disease condition. There has to have been other essential steps. So we have an office in Kenya, hosted at Kemri. For those who don't know, Kenya is my other home, so I've got a partial to Kenya. And then, more importantly, 2 years after the Lancet Commission report, we had the WHO declaration, a resolution on strengthening diagnostics capacity, which we all celebrated at the time, But again, it took some while to achieve that, but again, points to highlights my point about the world not responding appropriately to the finding that almost half of the world's population did not have access to essential diagnostics. In that same year, we held our first Find Diagnostic event, Diagnostics Day event, and then, of course, signed an MOU with Indonesia and entered into partnership with Gavi specifically as far as for diagnostics for surveillance of vaccine preventable diseases. Next slide. You've jumped one. Next, 2024. So, well, one of the fallouts or lessons learned, I don't know, consequence of the pandemic was the recognition of the need for regional or local manufacturing, or well, domestication of manufacturing of medical countermeasures. A strategy or an aspiration that FIND is very much aligned with. And as part of that effort, we supported, along with United, but we gave the most contribution to the regional manufacturing efforts in Africa through the commissioning of a factory for manufacture of rapid diagnostic tests at Diagnostics at the Institute Pasteur Dakar. What we intend to do with that facility is to hopefully go beyond the more theoretical discussions around manufacturing to demonstrate successfully the commercialization of an assay, which we well, thankfully hold the license. But we intend to go through the entire process with country about the market shaping, the new supply and logistics chains that you need to set up, and everything else to sort out demand and even hopefully have more predictable demand, in addition to defragmenting the market for, in this case, yellow fever test kits. This year, and I think during the high-level session coming up, we will hear some more on the updates from the Lancet Commission on diagnostics. So they have published an update last night about the progress or the lack thereof since the first commission report was published. In addition, earlier this year, we had the IPPS, this is International Pandemic Preparedness Secretariat, released its fourth 100-day mission implementation report, which again is freely available on their website. It says a lot about the gaps or the lack of progress, especially with diagnostics and therapeutics as far as pandemic preparedness and response are concerned. So obviously, because of the work which CEPI has been responsible for, we've had a bit more movement of the needle as far as vaccines are concerned. So a lot of new work on Lassa fever vaccines. CEPI has brought incredible attention to that particular virus, Marburg and the like. And we hope later this year to launch a strategy covering the 2025 to 2029 period. It's only been 23 years, but we are talking about FIND 4.0. So I guess we are like car manufacturers. We like our new models, don't we? Next slide, please. Okay, so again, a bit of an evolution. For those who don't know, we were set up as a product development partnership. At the time, it was believed that the problem was technology, or that you need to, the problem was the non-availability of products or new tools. But I think very quickly everybody recognized that if all Coca-Cola did was bottle their drink and put it in crates in the factory, then nobody will get to drink in my village, But, Coca-Cola is probably the perfect example of how to get things end to end. And in fact, for some of us, we've used the availability of Coca-Cola in a cold bottle of Coca-Cola in remote locations as a livable index. So if you arrive in the town and you can't get a cold Coca-Cola, then you can't live there. Because it means, all the supply chains and everything else that you need are not there. So, but So we evolved to a PDP plus, which then meant that we took on more work across the spectrum in terms of access, in terms of the work that needs to be done in country and with populations to make sure that products leave the factory and actually get into arms or into labs or wherever they need to go. And the figure shows how that evolution has occurred. I mean, certainly we remain very much aligned with aspirations for universal healthcare and global health security. And this continues to be the main plank on which we implement our vision to achieve diagnosis for all. Next slide. So I've said diagnosis for all many times. It's hashtag version of our vision, which is to ensure that everyone has access to high quality, affordable, and reliable diagnostics when and where they need them. Next slide. And the reason why we're still talking about diagnostics, again, as I referred to earlier, was this report, which shows that, almost half of the world in 2021, when the first report was published, lacked access to essential diagnostics. And that's the summary value. When you begin to look by geographies or by locations, it gets worse, or by level of healthcare. So when you look at primary healthcare clinics, it's terrible. It's abysmal. It's only 1% of primary care clinics and 14% of hospitals at secondary and tertiary level actually have the diagnostics that are required in many low and middle income countries. And if you started the day with us, you would have had a lot already about challenges with glucose strips, with malaria diagnosis, with access to even primary health care, people walking, mothers with babies walking 5 kilometers to get to a healthcare center and not finding a test. You know, and then when you look at things from the perspective of pandemic preparedness and response, appropriate tests do not exist for 60% of infectious agents with outbreak potential. Okay, and 50% of the top 20, and of course, for tests are not available for 50% of the top 20 diseases responsible for most lives lost. The right panel sort of gives you the idea of how the diagnostic gap is performing relative to the treatment gap. And you can see that there is a lot more of diagnostic gaps than treatment gaps. So the question I pose to my clinicians or frontline healthcare workers is, how are we treating people? So we're basically giving treatments without properly diagnosing patients, which means diagnosis is never early, because if you're lucky and the first differential is actually what the patient has, good. But if it's not, then you're like typical roadside mechanics in many parts of the world. You have a knock in your engine, so maybe it's the carburetor. Well, in the days when we had carburetor, does that, and then you go away, so, okay, come on, maybe it's the spark plugs. And you keep doing that till maybe the diagnosis ends up it's stage 4 cancer, or it's something. So we miss the opportunity for early diagnosis. Early diagnosis leads to early treatments, and for almost every um, disease or condition that I'm aware of, early treatment always has a better prognostic outcome. Okay, whether it's a communicable or non-communicable diseases. And we had earlier about, for example, how much treatment outcomes and cost of illness can be between an early diagnosis of HIV and instituting ARVs versus starting your treatment when you actually have full-blown AIDS with all of the opportunistic infections that you typically have. So we do need to move away, as I said earlier, from the provisional diagnosis or empirical diagnosis, presumptive diagnosis and empirical treatments, especially at this time when the tools we have are beginning to dwindle in number. We have increasing antimicrobial resistance, and the pipeline is not very good for most of the products that are needed. Next slide. So, what's our goal is to transform testing to accelerate global efforts towards UHC and PPR. And all of these disease areas are our priority areas, malarias and fevers, NTDs, hepatitis and HIV, tuberculosis, and so on. And then for pandemics, we consider traditional pandemic threats, and of course, AMR is a pandemic, even if it's not receiving the same attention as. And for all of these areas, we span across the spectrum: product development, clinical studies for validation. We biobank, we look at market shaping, we scan the horizon to gather business intelligence, and then we also do work in countries to help them be better placed to actually take up innovation. So the laboratory strengthening work that needs to be done, the diagnostic network optimization, and other bits of work that are more aligned with country-specific priorities. Next slide. That's to yeah. So what's the situation I'd find for 2024? In our effort to turn diagnostic innovation into health impact, we look at these various areas. So, for research and development, you see the number of items in the pipeline. 17 of them were diagnostic, and of course, as I mentioned earlier, we also supported one regional manufacturer for yellow fever RDTs, and we have RFPs for other situations as well. In-country work, there's a problem, and the updated Lancet report will talk about it. There's a problem with the progress with essential diagnostics lists. A few countries were pioneers. I'm actually happy to report, I think India and Nigeria were the first few countries to get lists, and others have, including the 5 that we've supported here. But for many countries also, there's not been a lot of progress beyond just writing the list. And the list itself, from when it was first written, has been updated or revised a few times. So the probably needs to be updated to that. As far as regulation and evidence generation is concerned, we have the list number of clinical trials and studies done there. We've done 12 studies for helping to generate data for regulatory approvals. We've also conducted 35 studies for even products that are not in the FIND pipeline, with a view of just providing the evidence that is required for public policy. And of course, we do have we are predominantly technicians, so we have related publications as well. But as far as policy and research outputs are concerned, we published 10 TPPs in 2024, including for glucose self-monitoring for diabetes, bacterial meningitis, cholera surveillance, enzyme immunoassays and RDTs, and work on TB. And of course, we've done the work on laboratory strengthening and overall capacity build. And we don't work in isolation. We know that there's an aspiration for health for all. We recognize that health for all will not be achieved if we don't have diagnosis for all. And all of these investments are all geared towards contributing to, obviously, sustainable, resilient health systems in countries. Next slide. I just wanted to talk, because we had a session on women's health and there was a conversation around, prioritizing. So there's a gap for everybody, but then there's a additional gap that is due to people being women. Okay, and it's not only about just sexual and reproductive health, because as we had earlier, actually only 4% of women's problems are related to sex and reproduction. Okay, the others are related to just differences in physiology and anatomy as well. STIs affect men different from women. Symptoms are very much apparent in men, much quicker. For women, less so, and then that leads to delays and then reproductive consequences. So all the blocked tubes and so on. And sadly, I think I left medical. I don't want to date myself, but I left medical school more than 2 decades ago. But STI diagnosis and treatment is still syndromic after 20 years, mostly syndromic after 20 years. So there is a need for new tools to enable community diagnosis or point of care diagnosis, and we are quite keen to bring into as a new product an RDT, a combined RDT that tests for gonorrhea and chlamydia trachomatis together. And this shows the timeline for, but the results so far have been very good. Gonorrhea part is sorted. I think the chlamydia bit is being tidied, and the idea is if that works, then they get multiplexed into the same test. And the aim is to have something that is cheap, comes to market at a very low price that allows you to detect individuals or make diagnosis at primary healthcare center level. Next slide. I mentioned specifically Dakar, but just to give a sense that we're not, I'm African. A lot of fine staff are Africans, but we're an international organization, and all of the populations we serve are spread across the world from Latin America to the Pacific. So we've got some completed work, some ongoing work, and some aspects of work that are aspirational um, in Latin America, India, Bangladesh as well. And the idea of the model we run for this is to, funding to support capacity expansion. And all we get in exchange for that is access pricing and hopefully volume guarantees. And then, of course, we provide technical assistance and then matchmaking to ensure that the necessary technology transfer occurs. Next slide. So for next slide, please. I'll just leave this alone. I talked earlier about EDLs and diagnostic network optimization as examples of in-country work because the access bit of our work beyond pricing, because everybody thinks access is only about prices, but it's not just about prices. It's also even capacity to take on and deploy new tools. And these are some of the work we've done beyond the essential diagnostics lists and that I mentioned earlier. Next slide. So an example of in-country work that I think the Minister of Health of Indonesia will probably speak to himself is our collaboration with Indonesia. And I'm highlighting this to just I like let country representatives present here know that you can't consider us a value added partner to your aspirations, but they have to be your aspirations. And the health transformation agenda in Indonesia is an Indonesian government aspiration, and all that we are working along with them to achieve their aspirations for strengthening primary health care through a number of interventions. So, obviously, improve access and use of quality diagnostics tools and enhance local manufacturing because they have an aspiration of procuring 70% of their health products from domestic manufacturers. And we are also working on cross-cutting enablers like digital health solutions, which I think in another session I attended earlier today, Minister Budi spoke about how they had no choice but to digitize the system, given that Indonesia is an archipelago with thousands of islands. How you have to find a way to make data move or be captured more efficiently. Next slide. Next slide. So for Indonesia, these were some of the achievements. We've sort of contributed to local manufacturing capacity by having boot camps with I think 34 um, companies within Indonesia, including Biopharma and Co. For the first time, there's a bit of work going on setting up ISO standards for open PCR. So Indonesia has made a decision that for PCR tech, they will use the open system, which is not as a platform, which means that you use across all disease areas. But what that platform is lacking is some form of an ISO standard that you can apply across board, and we are keen to help working with them set that up as well. Next slide. So let's talk about diagnostics, health, whether we, so clinicians and a lot of public health practitioners consider anything private or industry. Basically, you're on the dark side, if you know the analogy. But everything health has to do with economics. You cannot domesticate manufacturing without thinking about the finance part, the reward or return on investment part, even if that's not the main reason for doing that. So I thought we'll talk about some of the impacts of fine supported products that, perhaps highlight our value in the work that we do. Next slide. So this is like our, the diagnostics that we've supported since 2007 that have been commercialized. Everybody knows the Gene Expert platform. Guilty as charged. Find was responsible for helping bring that to market, and various versions. I mean, the various versions of the Gene Expert. A long time ago, I was part of. I worked for an institution that received global fund money to deploy fluorescent microscopes everywhere, and it was this particular fluorescent microscope. So that used to be the primary, or that was considered the immediate upgrade on light microscopy for diagnosis of TB back in the day before more molecular techniques were recommended. And I think it's to highlight for neglected tropical diseases, the human African trypanosomiasis tests as well, and of course many COVID tests as part of the pandemic response. Next slide. In 86 million fine supported tests were distributed in 2023. Of course, that included significant quantities for COVID tests, which then declined. In 2024, that number dropped to back to sort of the usual about 40 million for TB, HIV, and the other diseases mentioned there at the bottom. Next slide. In terms of disability adjusted life years averted by disease areas, we think, in 2023, the use of our products or products that we supported averted 5 million delis. And in 2024, that's 4 million. And the immediate sort of related economic impact is 15 billion in 18 billion in 2023 and 15 billion in 2024. That's an error there. Next slide. So a 10-year look, we've had 381 million fine supported pipeline diagnostic products distributed over a decade. 20 million delis affected over 10 years with $75 billion in economic value of health gains over the same period. And the fourth point highlights that, Ebola is infrequent. Human African trypanosomiasis is geographically restricted, but they had an outsized impact on how the contributions to wellness or averting disability, because obviously uh, uh, they had a significant, really great impact for that subset of population that are affected by those conditions. Next slide. So looking forward, as I come to a close, I hope next uh, next slide. Just leave that one. Next. So, as I said earlier, our interest is low cost point of care multi pathogen platforms in all of the categories, learning or taking forward lessons from COVID and some of the work that we've done, especially in the area of TB. The idea is, hopefully we will have products that can be used exactly at point of care, but even more importantly, can be used in communities for self-testing and the like. I know we've had conversations, or we are working with Meg and the HIV hepatitis team in WHO to actually bring update guidelines and bring products that for multiplex testing of HIV, hepatitis B and C to routine use and for community and self-testing. Next slide. Well, some of the investment portfolio, I mean, we would like instrument-free diagnostics because obviously they will be cheaper, but we recognize that some things will still have instruments. But the target cost of goods are shown at the bottom, and then the funding required, which, as you can see, shows that you don't need a lot of money to move the needle in diagnostics. You need money, but you don't need as much money as you need for vaccines and therapeutics. And the turnaround time of the whole cycle is shorter. In 2 to 3 years, most times, you probably of sustained investment and commitment, you probably end up with a usable product. Whereas the incubation period is somewhat longer for vaccines. I know people will talk about um, mRNA vaccines being available within a year. But I think what people forget is that before that, there's a decade of work on mRNA platforms for cancers and other things. So it didn't just appear for use in context of COVID. Next slide. Next slide. So that's the Diatropics factory. So we hope that for our strategy, this is what has happened. As I said, based on the feedback we've also received today, we're still interested in focus on advancing UHC and global health security seems to be the right one. But we think that given all that's happening in the climate, a new approach that begins to help the communities and countries we serve not to be just net consumers or recipients of technology, but to be co-creators and hopefully to own processes is the way to go. So instead of just being passive consumers, we hope that we take an approach where the countries we serve become more active contributors in the diagnostic space as well. Next slide. I think that should be the last. So just to highlight that we consider this an invitation to countries to engage with us. You can do one of three things. You can, of course, participate actively in our governance when there are opportunities, because then your viewpoints from your lived experiences from the constituencies you serve will be reflected going forward. Co-invest in capacity. The dependence on traditional aid models where one big funder pays for everything is dead. Okay, so we need everybody to chip in according to ability. So please, when you're doing your ministers and senior health ministry folks, when you're doing your budgets next year, you can consider putting in something in the envelope for fund. The return on investment will be significant. And then the third point is to please be available to co-lead the design and pilot efforts on for diagnostics to meet your needs. Like earlier this week, we met with colleagues from Lesotho who had a clear idea what they wanted us to help them with. So next slide. I think that's my last one. Thank you. Okay, so having, well, hopefully not bored you out of your minds, uh, we'll move on to the next session, which is the high level ministerial session, which will be anchored by our own board chair at FIND, Dr. Ayode Alakija. So over to you, Madam Chair.
Well, thank you very much, CEO, and thank you to all of you for being here today. I'm the light entertainment. That was the seriously heavy stuff. But we've now got the high level segment and we're expecting various ministers. It is wonderful to see so many friends, colleagues, Yukiko, ADG from WHO. It's wonderful to be here with you. Minister of State, my sister, been looking at you in the hall the last few days, thinking how wonderfully you're representing Uganda. It's great to have you here. We're expecting Minister Budi from Indonesia, who will be joining us shortly. This morning, we had a minister from Italy, we've had Zimbabwe, we've had various people coming in. I know it's a long, long day. You've all been at it since 9 o'clock this morning, so thank you for sticking with us. We haven't left the best for last, but we have left some fun for you to engage with. My name, as you've just heard, is Ayode Alakija, Dr. Ayode Alakija. Some people call me Dr. Yodi. I'm very proud to lead this incredible team at FIND and to lead the incredible work that we do around the world. So a very warm welcome to all of you. Also, this is a time of great change and turmoil for the world of global health. And this week has been interesting. I have had the very great privilege of having a front row seat in the Palais as the discussions have been ongoing, as we passed the historic pandemic agreement, which was co-led by our very own FIND board member, Precious Matsoso. It was an emotional moment. It was a powerful moment. But it was also a moment where we saw that from great, great difficulty can also come great triumph. A moment where we saw that mourning may last for a night, but joy comes in the morning. That is what we saw in Palais yesterday and the day before. And for me, it was a great moment of hope, of exaltation, because we at Find perhaps have been the precursor for many parts of the world in this area of transformation, this area of turmoil, because people now are talking about lack of funding and difficulties with funding. But we have gone through this already. So we were sort of the test bed, as it were. And I'm happy to tell you that it gets better. It gets better. You know, many of the people and organizations who we were talking to and speaking to in the past year or so when we were going through our difficulties and our transformation are now turning to me to say, Yodi, how did you get out of that? And so I'm here to encourage you all to say that it might look dark now, but it's going to get better. The world must come together. We must learn to lead and to serve the communities all over the world, not in with divisiveness, but with togetherness. We must learn that we're here not to play party politics or individual politics, but that we're here to serve humanity. That's what it's about. You've heard the scientific part of that earlier, you know, a lot of the science behind it, TPPs and various things. But in that room over there, in those rooms, in that over there, that powerful building, as I've sat there the last couple of days, I have watched people from countries across the divide be able to walk across and shake one another's hand. We don't necessarily need to agree on everything, but we're able to make lives better. And that, I think, is what the pandemic accord and that agreement and that consensus eventually showed us. So, having said that, I want to refer back to this morning and something very, very powerful that, as I followed online because I had other meetings, so we're sort of double hatting here this week. As I followed online, I listened to Carol from Zimbabwe, I believe, who spoke about her experiences from Zambia, who spoke about powerfully about her experiences of the lack of diagnosis, the lack of diagnostics, and eventually finding out as a young mother, widowed mother of 2 children, eventually finding out that she had HIV and she also had TB. You know, if I ever had wavered for a moment, just listening to her this morning made me realize that we do not ever, ever give up. We keep working because she is able to push through that now almost 20 years later, as she then incredibly said, with a 30-something-year-old daughter and a grandchild, literally brought me to tears. That is the reason we do what we do. And I say that to remind all of you, those of you online watching, those of you in this room, those of you who will watch this later, that that is the reason we do what we do. We are here to ensure diagnosis for all, but we're here to ensure health for all, universal health coverage, not just for people in low-income settings of the world. Our MOU with WHO signed last year, thanks to Yukiko and Adrian and the amazing team and Dr. Tedros. That work will go not just to low-income countries, but I've just come from Saudi Arabia, where they're partnering with us on work in AI diagnostics and more. The future is bright. The future is find. And we are finding a future together. We heard this morning from Deputy Minister from Egypt, Hatem Ammar, another board member, the fantastic work that they've done to test and treat hepatitis C, the return on investment for every dollar they spent. He didn't mention it today, but for every dollar they spent, it was I think it was 6.54, 654, what is it? Yeah, return on, no, yeah, dinar, yeah. Is it? Okay. Anyway, no, it was per dollar. Actually, it was a dollar return on investment in life, but you can't even count there the lives saved. This is what diagnostics does. This is what diagnostics do, and we are not getting that message across enough, because as we invest higher up the value chain, everybody has been mesmerized. And I'm delighted to welcome here also my new board member, Thomas Cooney, the former Director General of IFPMA. It's wonderful to have you here with us here, Thomas. And Thomas and I have locked horns and tackled and in various fora across the years, talking about vaccines and access to vaccines. But we agree on one thing: humanity is what matters. But I have to also say that as we talk about vaccines and therapeutics, you know, those are the sexy things to talk about. We have to remember that without diagnostics, we cannot, if you don't test, as Dr. Tedros said, and somebody else said this morning, if you don't test, you can't treat. So why are we focusing at the top end and forgetting the bottom end? Why are we focusing so much in billions in AMR, for instance? You know, for AMR, we were very privileged earlier this year. No, that was last year. Was that last year? It was last year. Oh my goodness. We were very privileged last year to lead a session on diagnostics, dive into diagnostics at the high level session ministerial on AMR in Saudi Arabia. In that session, we went deep, and Yukiko, you were there happily alongside me at that session. We were the only non-state actor that were given a place, because the Kingdom of Saudi Arabia, as much as they recognize the need to invest in the new product, they also recognize that if you can't test, you can't treat. And if you invest lower down the line and you ensure that people do not get actually hooked to this treatment with antibiotics. In my country, Nigeria, the voice, by the way, comes from the UK. My father sent me to a rather expensive boarding school, but myself and my person is an African. The other part of me is from Fiji, another part of the world that doesn't have diagnostics, where just the other day I heard that some young child died of dengue because we do not have point of care. But let me go back to AMR. In Nigeria, in India, various parts of the world, because it is cheaper to give somebody a bag of antibiotics than it is to give them a simple test. We have people developing antibiotic resistance, because if you have a mild fever, it's easier to say you have malaria, typhoid, and something else, and to give you a bag of antibiotics to go. How about we, all of us around this room, decide that instead of doing that, we will get rapid tests to everybody. Every mother whose child has a fever need not worry that that child is going to die, because she can do a simple test like we all did during COVID. And we know that where there's a will, there's a way. Where there's a political will, there is money. We must invest in diagnostics. So I've said enough for now. We're all committed to being a partner in the global health transformation here at FIND. As I chair this session, as we await Pak Budi, I'm going to first of all welcome Dr. Tedros, Director General of WHO, who unfortunately could not be here with us in person. As you can imagine, he's a little busy this week, but he has very kindly sent us a video. And whilst we watch that video, I will invite my panelists who are here to sit down immediately afterwards. Over to Dr. Tedros. Lights out, please. Thank you.
Teryodi Alakija, dear colleagues and friends, 2 years ago, the World Health Assembly passed a landmark resolution on strengthening diagnostics capacity. This week, we're reporting on progress so far. While gains have been made, there is still much work ahead. Equitable access to safe, effective, and quality assured diagnostics requires a comprehensive health systems approach. This means investing in diagnostic medical devices, particularly in a primary healthcare context, to facilitate early diagnosis. The sooner a diagnosis is made, the sooner treatment can begin, and the more likely it's that complications and costly interventions can be avoided. This is true for a wide variety of diseases and conditions, including hypertension, HIV, and cervical cancer. WHO's 2025 campaign, Healthy Beginnings, Hopeful Futures, recognized the importance of increasing access to diagnostics in women's health. In addition to better access, we also need investment in research and development for new diagnostics for major emerging threats like antimicrobial resistance. I thank FIND for its commitment and advocacy. Together, we can harness the power of diagnostics for a healthier, safer, and fairer world. I thank you.
Thank you, Dr. Tedros. It's like we were reading from the same script, because he also mentioned AMR. He mentioned hypertension as well, and I also want to refer to NCDs as I invite my panel to join us. Minister from Uganda, please do come up and join us up on stage. Yukiko, please join us. I will say that Yukiko is going to have to leave early. Pak Budi from Indonesia is incoming, I'm told. And the other person on my panel is from the Lancet Commission, I believe. Are they here? in the room? He's joining us on Zoom. Okay, wonderful. Okay. It's interesting that we refer to the talk about the Lancet Commission. Hello, Helen. Welcome to the 100-day mission. We talked about you earlier. We CEO referred to the Lancet Commission earlier in the report that was just launched. I urge you all to read it. I had the very great honor of reviewing that report, and I'm very glad that it has come out and it's been launched today in sort of alignment with Diagnostics Day today. I'm going to go very quickly, if the Honourable Minister will allow me. I'm going to go very first to Yukiko, ADG from WHO, who is our dear partner and also who has to leave shortly. In your new role, which you will start in a few weeks, so also do please join me in congratulating Yukiko as the new role as ADG for health systems. But Yukiko has typically worn the hat for AMR and yes, and so has been our partner anyway. So she re-inherits us again. I'd like you to speak to what WHO is doing to support the implementation of the diagnostics resolution, and also to a little bit of what our MOU, which we finalized and signed last year, what that means to the world. Thank you, Yukiko.
Thank you very much, Dr. Yodi, my dear Yodi. And then thank you very much for the pricing about my new role. And then and also thank you very much, Fine, for organizing this important event, advocating how importance of the strengthening the diagnostic capacity. Also, this opportunity is absolutely the honored and the privileged for me to leading of the current my responsibility to ensuring the access to the quality assured health products, and also acting the ADG on the antimicrobial resistance program. Then I very much honored to share for what is the progress based on the WHO resolution 2 years ago. I have the few bullet points, but I will be quick. But first, thank you very much collaboration with the FIND and also the many partners collaborate to ensuring the access to the diagnostics. Then particularly we can have the MOU together with FIND last year, just 1 year before. This is something, the very good example how we can collaborate between the WHO and the partners to leading the exact program. Then the meantime, so we work on the providing the norms of the standards on the health product, including the diagnostics, of course. And also we revise of our framework of the global benchmarking tool on the regulatory system, which expands to the medical devices in last year. And also, I'm very much happy to announce of the side event this evening for the announcement, formal launching of the Global Diagnostics Coalition, the 7:30 in this evening at the Palais. This is a diagnostic coalition. So it's like strengthening the network of the international partners and the members states to supporting the work on the diagnostics. And also, this kind of the partnership, it's the increasingly very much important because of the current situation. And then, as you know, the WHO needs to downsizing our organization to focus on our core mandate. But the meantime, we need to increase the collaboration with the institutions and the partners, member states outside WHO to share some role and also make sure the achievement. So WHO needs to focus on the coordination role rather than the providing the support itself. but also needs to lead of the which direction we have to go, which output we have to get until the when. So we can discuss more detailed with all the partners together. So this is something that we want to achieve with Find also. Then also we want to provide a very good example together with you, and also we together with all of you. Then also we are achieving of the technology transfer on the platform technology of the rapid diagnostics a few weeks ago, which is the platform technology providing from the Korean local manufacturer to the Nigerian local manufacturer. This is the first case of the new initiative of the Health Technology Access Program. This is also important to leading the technology transfer. This is part of the implementation of the pandemic agreement, which adopted yesterday. So we have to go forward through those all the initiative. Then also this is talking. They are very much broader scope, but what I want to leading as a new my responsibility for the ADG of the health system is the absolutely taking to the comprehensive approach to ensure the access to the health services, particularly diagnostics. This is very much important to avoid the unnecessary treatment and also the increasing for the quality of the healthcare. And also this is absolutely important to the earlier detection of the cancer, of the something crucial diseases to saving the more lives. And also, for example, cervical cancer, you are very much engaging the working with us. So comprehensive approach, including the R&D, regulatory system strengthening, make sure the supply chain, the management on the healthcare workforce. We have to train the healthcare workforce and changing, the improving the clinical guidance, and also health financing. So we make sure for the affordability of the all the technologies, imaging device, all those. So and also the data and the digital AI. So all those I mentioned, that's functions under the health system. Huge task. Absolutely, I need to ask all of you, please support WHO. Please work together.
Absolutely.
Yeah, so yeah, I'll stop here. Thank you very much, Yori.
Thank you so much, Yukiko-san. Thank you. Um, you know, we absolutely do support WHO. And as you know, one of the hats I wear, of course, is as the chair of the ACT Accelerator. And as we now wait for the pandemic agreement to go and come into force, one of the things I've been discussing with Dr. Tedros and with Mike Ryan as he transitions out and whoever, well, Chikwe coming in, but whoever takes over the ACT Accelerator, is that we need to revamp that mechanism to fill in that gap. And as WHO now has reduced resources, we all must step up into that space and sort of not be tripping over one another, but actually be working collaboratively very closely together. So absolutely, we're with you on that. This is a ministerial panel, and because I have another minister, my own minister in the room, my assistant minister Hatem Amr, I would like to invite Hatem to join the panel, please. Find board member. See, you're playing swapsies with Yukiko. Find board member Hatem Amr is from Egypt, and I will, before Hatem speaks, I'm going to hand over to my sister, Honorable Margaret Muhenga, Minister of State for Health for Uganda. Uganda, you also championed the diagnostics resolution, and we're very grateful for your advocacy. And as we say that, I also want to recognize a dear sister, Philomena Similane, who was the lead negotiator for the WHO resolution on diagnostics from the government of Eswatini, who we lost a year or so ago. And I would like to recognize her great work again here today. But over to you, Minister. Can you tell us a little bit? I mean, you've done some incredible work, and my sister Jane, do please give her my warmest regards and a big hug. I sent her congratulations when you got over the latest hurdle. You keep, you deal with Ebola, you deal with all these threats every day, and the world, we need to recognize that diseases start and they end in communities, and they start and they end with the work of people like yourselves in countries. Could you please tell us a little bit about that?
First of all, I would like to thank you, Find, for this very important meeting. And I should be also start with saying that diagnostics is very important in every healthcare system, because that's how we get to know the diseases that we're suffering from. And the lack of it has actually caused a lot of trouble. A lot of people do self-medication, which leads to antimicrobial resistance, which is also now yet another challenge for the world. But I want to say that in Uganda, we've really taken a leap forward. We have got Uganda National Health Laboratories. In the last at least 10 years, we've been able to diagnose most of these diseases. If you recall, Uganda is at the equator. It's a tropical country with the best climate in the world. But also that climate comes with a lot of challenges. The challenges are outbreaks, pandemics come from around that Congo basin. So we are really prone to so many outbreaks, like Ebola virus disease, Marburg. We've had Marburg hemorrhagic fever. It was in Rwanda last year. We have had 8 outbreaks of Ebola in the last 20 years. But also we have broken a record, a world record, where we fought Ebola in a record time, 69 days in 2022. This year alone, we did have Ebola for less than 3 months, from January actually to February, and were declared Ebola-free by the WHO. This is thanks to their diagnostics that we have, because it's quick, it's now swift, that we can pick a sample from anywhere in the country and have it at the national laboratories. We've also done a lot of research on these pandemics. And I would tell you that one of the best things we had during COVID is that Uganda was one of the best performers during COVID. You remember? And we were recognized and given even an award for being one of the best 10 countries in the world in the fight against COVID. It was not easy, but our scientists took it to another level. Our president put us in a lockdown for nearly 2 years, but we died less because we are susceptible to all these pandemics, and so we have that resilience and preparedness to fight them. I want to re-echo the words of Dr. Ayo. I won't say your full name because it's difficult. But Dr. Ayo, you highlighted something to do with humanity, which is really important. You know, most countries and most people talk about economic growth, money and things of this world. They forget there is humanity. Once we go back to humanity, go back to the basics, this world will be a better place to live in. And doctor, whose name I've also forgotten, also today at least gave us one of the things that I didn't know, that nearly half of the world lack diagnostics for the most of the diseases that we get. Indeed, imagine if somebody had HIV and wouldn't be able to know that they have HIV, or even any other life-threatening condition. This person is ravaged to the core before they get to know what they're suffering from. So it's very important for us at primary health care to have these diagnostics. We have a plan in Uganda to have a health facility every 5 kilometers from where humans dwell. We haven't gotten it 100%, but at least 70% to 80% of our population can find a health facility 5 kilometers from where they live. transport is not that great, but at least they can get there either by walking or a motorbike or even a bicycle, a normal bicycle. And this has helped a lot fight diseases, and that's why our population is growing very fast. We are actually the fastest growing population in the world, and we have the youngest population. Half of the 46 million people are below 16 in Uganda. So we have a human resource that will go a long way to develop the country. So lack of access to diagnostics is really tough for us. If we can have these laboratories at every point that I'm talking about, the lowest point to be accessed by the communities, it will go a long way to detect, because early detection is very important. This world can only be safe when everywhere is safe. And we saw this during COVID. Because if I have, let me say, Ebola, and I live in Uganda, and I have Ebola virus disease, it takes me only 6 hours to be in the EU. I travel on a plane. I will infect everybody, nearly everybody on the plane, because it's highly infectious. I'll enter the EU. I'll be able to move in a train before I show any symptoms.
Absolutely.
Infect everybody on that train. And because here there's a lot of movement, unlike people in Africa who live in their own homes, in their villages, and the interaction is less, I'll be able to give everybody that disease. Fighting it within here would be very difficult than fighting it when you are back home in Africa, because the interaction is not that much. So empowering these communities to have diagnostics, to find these diseases at the earliest point, is very important. And I want to thank you, FIND, for this initiative.
Thank you. Thank you, my sister Margaret. Thank you so much. So well said. You know, as you spoke about Ebola, I remembered the being in the heart of Ebola in 2014, and as it, you know, for the first time really began to ravage West Africa and ravaged our country, Nigeria. You know, lost a couple of friends and people that one knows from exactly what you said, that there was, and we had no diagnostics, was very difficult because it was something we were not accustomed to. I'm going to go from you from a policy level to Hatem, for the Assistant Minister from the Ministry of Health in Egypt, to speak on the return on investment of diagnostics. I mean, you are the poster child for return on investment, that incredible work that you did. And I know you spoke a little bit to it earlier, but I think just the sheer scale of the numbers, I think I completely got it wrong just before you walked into the room. So I'm going to allow you to tell us what that return on investment is, and also as your chair, to officially welcome you to FIND and to the board.
Thank you very much, my dear sister, Dr. Yodi Alakija. It's a pleasure to be here, and again to very briefly shed some light on the importance of diagnostics. So, as my sister, the Minister of Health in Uganda, mentioned, that access is very important, and there are a lot of people in rural areas, in remote areas, that do not have this accessibility. And without access, without diagnostics, without detection, and without treatment, millions of lives are lost. And it is very, very important to highlight the importance of early detection and prevention. And this is where Egypt started this very ambitious plan in 2018 to eradicate hepatitis C. As most of you know, that Egypt had the highest prevalence in the world of hepatitis C, and 2 decades of work, planning, and ideas of how to put an end to that. But it required a very strong political leadership in 2018, when the president took it upon himself and directed the government that we have to eradicate hepatitis C, and that the people are suffering, and enough is enough. So the government, together, they partnered with the private sector, civil society actors, international organizations, pharmaceutical companies, both domestic and international, and we localized the drugs produced in Egypt, decreasing cost of treatment from 25,000 US dollars in the United States to $1 in Egypt. And
say that again.
what, yeah. costs $25,000 for treatment in the United States, while it costs $1 in the Arab Republic of Egypt because of localization and local production of those drugs. And this massive campaign that started in 2018, we were able to screen 65 million people. Huge number, 65 million people, not just Egyptians, but Egyptians, migrants, refugees, everyone that is living in Egypt. The Egyptian population is 107 million. We have more than 10 million migrants and refugees living within Egypt. And this campaign screened everyone 12 years and above. And out of the 65 million people that were screened, 4.5 million received treatment for hepatitis. And from there, last year, Egypt became the very first country in the world to receive WHO certification of eradication of hepatitis C, golden tier status on the pathway of eliminating hepatitis C. So highest level of prevalence of hepatitis C to number one country in the world to eradicate hepatitis C.
Come on. Come on.
And this, as you like me to always point out, it requires several things. Very first thing, very importantly, very strong leadership and political determination that things have to move no matter what the obstacles are. Involving the private sector, the government alone cannot do it. Involving civil society actors, campaigns for awareness, reaching the most rural, secluded areas, mobile clinics, availability of diagnostics and treatment. And equity is very, very important, leaving no one behind, as was mentioned repeatedly. Migrants, refugees, people in most vulnerable situations, everyone has a right to diagnostics, access, and healthcare. Now, to finalize, I will also leave another staggering number. The government put out the investment out of our national budget before we received the funds that we had agreed upon with the World Bank. And this funding that the government put, the return on investment is 350+%. 350+% for every dollar that the Egyptian government invested. And one last thing, this does not stop in Egypt. We've reached out to a lot of our brothers and sisters in Africa to how to cooperate. We've went across our continent to Pakistan, to other nations to work together, to partner and to learn from how Egypt worked on this, what we can learn, what we can do together, what we can improve and do better, and what we can learn from other experiences from other countries in the world. Thank you very much.
Thank you so much, Hatem. And I mean, can you all please join me in giving an incredible cheer to that work? It is powerful when you speak about it in numbers. And I'm delighted that as you are speaking and as you are leaving us, that I'm about to bring up somebody who himself is a numbers man, a banker, a financier, not necessarily a medical doctor, but somebody who is shaking up the world of global health. It is my honor to welcome to the stage His Excellency, fondly known to me and us as Pa Budi, but His Excellency Budi Gunadin Sadikin, Minister of Health, Indonesia. Your Excellency, please do join us up on stage. No, Margaret, please stay there. we can't make him feel lonely. We can't make him feel, you're Africans, you have to be warm. Indonesia, Your Excellency, first of all, thank you. Thank you for being here. I know that you're under incredible pressure this week, but Indonesia is a strong partner of ours at FIND, and Pak Budi has been incredible in our partnership. We recently signed MOUs and also implementation agreements, and we work quite a lot in Indonesia. I was recently there, and yesterday I ran after you because I was wearing my Indonesian batik my batik jacket, just to show it to you. So Indonesia is very much our partner. You're also one of the champions of the Diagnostics Resolution and highlighted as you led diagnostics as part of your presidency of the G20. I have a couple of questions. I mean, you could, of course, speak all day, and I would love you to speak to those experiences, but I would also like you to refer to, from your financial side of your brain, the need for investment in diagnostics, because we are so caught up in finding shiny new drugs and tertiary care, as you and I have often discussed, hospitals and treatments. how do we prevent? How do we detect early? How do we save money? How do we go to the Puskesmas and make sure that people are safe there? Over to you, Minister.
Good afternoon, ladies and gentlemen. Yodi, my sister, thank you for giving these opportunities. As a banker, when I came in, I checked the numbers. Typical. How much money the Indonesian as country spend every year on healthcare for our people. The number is around 40 billion US. And if I Google, it's consistent with the average health cost per capita of Indonesia, which is 142 US dollar per annum per capita. 280 million, so the numbers around 40 billion US. And as banker also, I love to work with target. So what are the target? Why we spend so much money to make our people healthy? So what is the measurement? The measurement that I use at that time is the average life. Indonesian average life is 72. So we spend 140. So I start screening the other countries. Of course, I go to the US. The average life is 79 and they spend 11,900 US per capita per annum. So I always have a joke with my friends. It's Javier Becerra, he used to be the Secretary of Health and Human Services, United States. If I were your citizen at 70, when I reach 70, I will migrate to Cuba and Panama. Why? Because in Cuba and Panama, the average life is 79, the same as US. But they spend only 1,900, 10,000 US dollar difference. So I will live in Cuba and Panama. I can use the 10,000 saving every year to go to Bali. Of course, then we have a funny about you cannot compare me with that country. Okay, compare to Japan. 84 years average, more than US. They spend only 5,500. Or you come to South Korea, 83.9. It's very similar. They spend 4,000-ish, 4,400, 4,800. You can Google it or chat GPT and doing that. One of the most efficient is Singapore. 84 years average life, 3,300. My closest neighbor, Malaysia, 76, 430. 300 US more. Singapore is 3,000 US more. I'm 61 this year. 60 last year, I ran Berlin Marathon last year. So I feel in the next 5 years, Indonesia will go to Malaysia level. Average life will increase from 72 to 76. Our population will age. And of course, we'll spend more money. Assuming our healthcare system is as efficient as Malaysia, which is we are not, then we will add additional 300 US per capita. Multiply by 280 million, that will be 84 billion US dollar. Our national expenditure will increase from 40 billion to 120 billion US dollar in the next 5 years. If we go to Singapore level, 3,000 US difference, 84 years old. 15 years later, 20 years later, 3,000 US difference, assuming there is no inflation, then you multiply by 280 million Indonesian, 840 billion US dollar. Half of our existing GDP right now. So that's why it's unsustainable. Unsustainable. That's why healthcare is expensive. And now the question is, why Singapore is 84 and they spend 3,300? Why US is only 79, they spend 11,000? When I do some research, hire McKinsey and Boston Consulting Group, all the smart guys, it's very, very clear. The country that spend their money on promotive and preventive, the cost is much cheaper than when you spend the money on curative. To keep people healthy is much important than to cure sick people. I'm sorry, not more important, but it's cheaper and better quality of life. It's cheaper and better quality of life. So that's why it's important for you to do screening, to do diagnostic. That's why last February the 10th, we launched our most ambitious program. We will screen 280 million Indonesians every year. Mandatory screening programs. When you talk about Indonesian mandatory, they will run away. So we share this program as a birthday gift screening program. And you tell them this is a birthday gift, and birthday you annually it happens until you die, right? If you have birthday every year, then Indonesian will like it. So starting on the 10th February, 6 newborn screening, 8 screening for below 5, 11 to 13 screening for schools, so age 7 until 16, 17, 19 screening for adult, and 19 screening for elderly like me. All major diseases. Now, per yesterday, 6 million. So starting from 10th of February until now, 6 million already screened with a running rate 200,000 every day. So around 5 to 6 million every month. I would like to increase that to 300 to 400,000 every day. So my target, hopefully by this at the end of the year, it will be reach 50 to 60 million, and hopefully by 3 years it will reach minimum 250 million, and we will have the most comprehensive cohort of clinical data of the Indonesian populations. And we do hope that this can, and I'm very surprised to see the numbers. Below 60, like me, 44% hypertension, 20% diabetes. Pre-hypertension, 20%. So hypertension is 60% for above 60. And of course, we send them to Puskesmas, get a free amlodipine. If you have a diabetes, you can go to our primary healthcare clinics and get the free metformin. You have cholesterol, you can get free statin. But I believe if you do a proper screening, it will be reducing the cost in the future. That's why it is extremely important for you to do screening. And I'm already get the money from the World Bank, 1 billion US dollar to equip 10,000 Puskesmas with hematoanalyzer, blood chemical analyzer, EKG, ultrasound, etc. So hopefully, and all those screening data will be used by the Ministry of Health to do early intervention and reduce costs. So that is my advice. Keep our people healthy. No G20 ministers, the title is Minister of Sickness. Title is Minister of Health. Our job is not to kill sick people, that keep people healthy.
Pabudi, I'm going to let you take a drink. But as you take that drink, I'm going to reflect on a little bit of what you just said. I mean, what blew my mind when I visited a couple of years ago and also more recently in Jakarta, and thank you for the warm hospitality, was going down into outer islands and the very, we arrived on a boat and then we drove for 5 hours into mountains and various places, and still we got to this incredible health center where there were diagnostics, there was rapid tests available, there were, we got to the sub level where there was laboratory facilities, really quite advanced laboratory facilities, seeing the use of telemedicine to do training for ultrasound. I mean, you have done an incredible job for a country of your size and of your complexity. And I think that is, it's important, because when we talk about reaching people at the very last mile, what I saw in Indonesia was the very last mile, the accessibility to, for me, the one that blew me away the most was the RDTs. Just in every little Puskesmas, there was an RDT, and there was a trained health worker. And some of the work we're trying to do, we at FIND are doing with you, is laboratory strengthening and working with those groups. But can you just give us a little bit of that vision so that those of us here in the audience and those online can learn a little bit about it?
So first, technology move extremely fast. Technology move extremely fast. So first, as I mentioned to you, we do the RDT, they call it the rapid test, is massively now become more accurate. I give you another example: the screening for HPV. Just launched the new screening, the HPV DNA, for 60 million Indonesian above, I think above 21 years old. And the screening now is you can use a self screening because PCR is available everywhere. No, we are deploying 514 cities with all PCR. By the way, Indonesia have 38 provinces, 514 cities, 10,000 districts, where our lowest primary healthcare clinic is there, and we have 85,000 villages and 300,000 hamlet at 7,000 inhabited islands. 7,000 islands. So then In my time, I would like to reduce from 10,000 healthcare facilities, primary healthcare, to 85,000 villages. So now the progress is ongoing. Already we established 57,000 out of this 85,000, all digitalized, have a Starlink connections because that is the best internet connection because we would like to digitalize everything. So what we do is we use the latest technology. HPV DNA testing for is impossible. I give you an example. Now we can do a swab done by the mothers and then put it in it's like a PCR testing and send it to the lab. And in one day, you can get the result back and send by WhatsApp messages that this is your positive or your negative in terms of HPV viruses. Now, what we are doing, we would like to democratize tuberculosis testing because TBC in Indonesia is 1 million. But the cheapest test now, the molecular biology testing, is $8 per test. Can you imagine? I have 1 million, means that theoretically I have to screen 10 million people every year. You multiply by $8, it's 80 million US. It's very expensive. The new technology now, we are working, I will meeting with a guy. It is supported by the Gates Foundation. I will get it to 4. Maybe I get it to 3 or 2.5 US. But that will cut the half of the screening method. It's not only that, about the I mentioned to you I sent ultrasound to 10,000 prisoners because child mortality is very high. 30,000 babies die in Indonesia because we don't have enough ultrasound. Now ultrasound is very cheap. We are deploying now the EKG because heart disease, heart attack kills number 2 in Indonesia. So we send the EKG to 10,000 puskesmas, get some AI and telemedicine to these specialists. And when you see the potential ST elevated, whatever myocardiac infarct indicator, then we can inject with tenecteplase. So we will do thrombolysis at the puskesmas. So it will save life. Now with the World Bank money, the 1 billion, I have some saving. I'm thinking to put 10,000 X-rays, mobile X-rays, because now it's getting cheaper. You can get in only 6,000 US. You can get an X-ray. You put it to the puskesmas. They can do a lot of things to the primary healthcare clinic. So, ladies and gentlemen, embrace the new technology. It's much cheaper, and with AI and internet connectivity, you can use a lot with the same quality as what you have seen before can only be done at the hospital.
Thank you very much, Pabudi. Just brilliant to hear. And um, I mean, for me, the idea is racing around my head, but even as I see you sitting next to my sister Margaret from Uganda, and think about Yukiko just left, and had him here earlier. The opportunities for collaboration, the opportunities for South-South collaboration also, but the opportunities for lessons learned, and what you're saying for us to begin to look at health from a different aspect. I loved what you said about nobody's called minister of sickness, it's minister of health. And that alone, that simplicity alone, I think, is something that we need to begin to stress. The linkage of finance and the return on investments, for me, it's a huge focus, because we have shrinking purses all over the world. I mean, we've just seen this complete, well, Papudi's laughing. He's like, it's not shrunk, it is not shrinking, it's disappeared. Yeah.
Sit at the board of Gavi. I put also several of my vice ministers sit at the board of Global Fund. I'm a friend of Sania Barroso and also Peter San, my dear friend. And they're looking for money. The replenishment should be done this year. Yeah, it's craving for money. As a banker for 30 years, I'm a banker. I have zero background in healthcare. So I have 30 years in banking. I told Peter San, Peter, you and I, we have raised trillions of US dollar for our clients in the last 30 years. Be honest, so much money, but so little contribution to humanity.
Yeah.
That's what I feel. Now we are raising to, it's only like 16 billion. Global Fund 16 billion. I just realized WHO budget is only 2 billion. Even I raised 4 billion from World Bank in 6 months. I think, Edros, you should be able to raise 2 billion, because you are a much larger organization. Indonesia raised 4 billion with the syndication of Development Bank, and we finished that fundraising in 6 months. So my feedback to all of you that working in healthcare, the money is there. There are a lot of money in this world. I invited Bill to come to Indonesia, Bill Gates to come Indonesia 2 weeks ago. He is spending 9 billion every year, grand. And he will finish 200 billion or whatever money that he has until 2045. So the money is there. Now the problem is how can we convince them with the right programs to get money? So I don't understand why it's so difficult and a lot of people are complaining. You know, I have 1 billion US dollar every year rolling grant. My budget is 6.5 billion. I just realized it's bigger than Tedros' budget. My country budget is 6.5 billion. I got cut 1 billion by the Minister of Finance. Every Minister of Finance now cut everything. You know, it's not only the government's US. Everyone cut everything. You know the issue is I don't complain. Why? The I lost 100 million from USAID. Not because USAID doesn't like me, but the USAID is gone. You know, so suddenly my 100 million commitment, whom to I talk to? There is nobody to talk to. But then easily I move to defense. Australia is number 2 contributor to me. I don't know whether any Australian is here. So I talked to Penny Wong. I know the one that have the money is not the Ministry of Health, but Ministry of Foreign, Foreign Ministry. I talked to Penny Wong and Penny give me money. So it's as simple as that. And then if you lose, 1 billion, I go to World Bank. Budi, you want to add additional money? Ajay Banga used to be my friends in the banking sector. You want to have a money? I easily can give you 1 billion. Go to AIIB, give me another 1 billion. Now I'm confused. What this 1 billion I would like to use to? Maybe I will use for HIV program. So, friends, the money is there. The terms might be different. Maybe you get free money usually. Now you have to pay interest. But you can buy down the interest to reduce the interest. And for me, I don't believe that you have to live with always free money. I talk to all my friends, the Minister of Health developing country. If you believe that you always live by grant, you will be a poor country forever. It is like you give money to your children until they reach 50 years old.
I couldn't agree more.
It's very ugly things to do.
Yes.
You don't educate your children. The children has to be independent. So have a very clear health financing pathway. 5 years, I live by grant from whatever Gates Foundation. But 10 years, 50% grant, 50% concessional loan. 15 years, 100% concessional loan. 20 years, I own money. 25 years, I become a donor. Oh, like Gates. I give
Alhamdulillah. 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 On that note, let me quote my brother Tedros, who said that 2.1 billion is the equivalent of global military expenditure every 8 hours. 2.1 billion is the price of one stealth bomber. 2.1 billion is a quarter of what the tobacco industry spends on advertising every year. But it is what we value that we as a world, and it goes back to my comments at the very beginning about humanity. It is what we value as a world that we invest in. But we need to start to speak, and which is why I wanted you, Pabudi, to speak today. We need to start to speak the language of investment. We need to start speaking the language of not being on the recipient end. And for my African sister and my African brothers, I call for Africa, all of you in the room today who are from Africa, the Abuja Commitment 2002 Abuja Commitment. We need to begin to increase our health spend, because it is he who pays the piper dictates the tune. They will tell you what to do with your health. They will tell you who must live and who must die if they are paying the bills. But if you are paying the bills that yourself, you will decide, like Pabudi, who lives and who dies. He's not God, but he will invest in all of his systems. He will not only invest in some of his systems. He will not only invest in his pet projects. I see my sister Margaret needs to go, and you. Thank you very much. I'm going to excuse you as we go into the next segment. But this is critical. And as an African minister, please, as you go to the other African ministers, carry this message: increased health spend. We need to begin to put our money where our mouth is. We cannot have our hands out all the time. World Bank is not World Bank money. It is our money. We're paying for it. So let us use it responsibly. And with that, I thank you both. We're going to go very quickly before Margaret leaves, because I want her to be a part of this launch. She's laughing. My sister, where are you going? I beg. It's okay. Don't bully my sister. What is it? What is it? We're going to have an exciting launch right now of this Lancet report. I believe Sabine, who's a deputy editor, is here in the room. Welcome. Thank you very much. And online, we have Michael, who is going to this report, Moving the Dial on Diagnostics, an update from the Lancet Commission on Diagnostics. I'm very proud to say that a couple of our own team here at FIND contributed to this report, and the first printed copies are being made available here today. Like I said, I had the honor of reviewing it. I can tell you it is very good. So over to you, Michael. Sabine, please do join us in front.
Thank you, Yodi, and thank you for the opportunity to participate today. Reflecting on what the previous speakers have said, I think at the launch of this report is a very timely thing because it definitely dovetails with the work that we've done over the past few years. What I'd like to present today is the findings of the update on our commission work. And just to remind everybody, the timetable was that the commission was published in October of 2021. And we made a number of recommendations in that report, many of which we were able to work with member states, World Health Organization, to put those into the World Health Assembly resolution on diagnostics, which came out in May of 2023. The work on the Lancet update became in 2024, just shortly thereafter, to report on progress. I think everybody realizes that just a single year was not a lot of time to measure different metrics, but we've worked on that over the subsequent 18 months or so, and has been stated previously that the report, the update became available just today. So the 10 recommendations that came out of our commission do, as I mentioned, do dovetail nicely with what was in the WHA resolution. And the first of those was the member states should develop a national diagnostic strategy, one part of which was a national essential diagnostics list. And I think that it'd be very fair and accurate to say that there's been very good progress on both the WHO EDL as well as the national EDLs. As I'll show on the next slide, this is the figure that comes from the update, and it's a very busy figure because there's actually a lot of information. But there are a number of states that have already published a national EDL or an EDL-like document. Implementation is underway in some countries. And there are a lot of countries right now that have what is called a national priority list. So when we think of essential diagnostic lists, we can't be too literal about that because another number of countries have already established priority lists that they use for procurement, distribution, and so forth. So this is an area where I think there actually has been amazing progress, considering that work only began on essential diagnostic lists just a few years ago. It really took off around 2017 and 2018. I think this is just amazing progress that we've seen over just a relatively short period of time. I think that everybody deserves a lot of credit for this. FIND has been heavily involved in working on this, and I think that this is just something we should all be very proud of. The second recommendation from the Commission was about access to diagnostics for key conditions should be available at the primary care level. This is one area where we just have both insufficient data and insufficient time to really assess the impact. As a previous speaker was noting how difficult and how long it takes to get things out into the primary care level. I mean, the numbers he gave from Indonesia are really impressive, going from 10,000 to trying to get to 85,000 different locations. So this is something that will simply have to be tracked over the upcoming years. The third recommendation was to invest in workforce expansion and upskilling. I think there have been some very encouraging recent examples. There have been several, for example, in Africa that are really show that people are taking this very seriously and working hard at this issue. But I think that it's fair to say that globally progress is somewhat more patchy and it's just not at the scale needed to meet demands. As we noted in the original Commission report, I mean, we're going to need at least 1 million workers in the next few years in the area of diagnostics. And right now, we just don't have the scalability to produce that sort of a workforce. But again, there are some really encouraging recent examples, which hopefully will lay the groundwork for other member states to follow. The fourth recommendation was to commit to regulatory frameworks. WHO has a good framework available, a model framework, and I have to admit that there's been some really good progress in Latin America, Africa, and Southeast Asia. A number of member states are really beginning to take this on. And I was at a meeting from the meeting called ESCMID Global about a year ago, where they're talking about some of the regulatory harmonization in the EU. And I think that we're starting to see a lot more of this interaction between member states to really harmonize and help develop regulatory frameworks. So I think there's been very good progress in this area. The fifth recommendation was to roll out a national financing strategy. And there are some really good examples in our update on this, one from India and one from Brazil, where we've seen some really amazing progress actually about how you can do national financing. I think that it's also important to remind everyone that, as we've talked about in the last few minutes about return on investment, in our original report, for a number of different diseases and conditions, the return on the investment is anywhere from 4 to 24 times what the investment would be. I mean, I think there's very good evidence, very believable data that the return on investment in diagnostics is very solid. And I'm glad that others have been raising that issue, because I think it's something that we really could emphasize a lot more. The sixth recommendation in our original report was on improving the affordability of diagnostics. There definitely have been some successes in this area, but it is really difficult to measure impact globally. I mean, there have been a couple of really interesting things from MSF and the Treatment Action Group, as well as Global Fund, working, for example, on affordability of gene expert cartridges. I mean, this is just one example that we cite in our update, but I think there are others underway right now. But again, this is such a diffuse area with so many member states involved in so many programs. It's not easy to actually measure the impact, but I think another one that we need to track over time. The seventh recommendation from our commission report was to develop and use technology in ways that can benefit everyone. I mean, I think we're seeing the massive explosion in technologies such as AI and other informatics technologies. Also, lots of advances now in different types of advanced diagnostics. But of course, we all know that when you try to look at the impact of these advances on health outcomes, that takes a very long time. I mean, some of the impact in outcomes, this is going to take 5, 10, 20 years to really know what the final impact will be. But certainly, as we note in our update, there is a lot of movement in this area. And I think this is another one we just need to track over time. Our eighth recommendation was to address the needs of populations living in conflict situations. There actually has been really good progress, I think, made in this area. WHO, between the emergency group and the strategic advisory group of experts for the EDL, are working together to develop an EDL for emergency and humanitarian crises. There's been a lot of work done in just the last 6 months. This is moving along very nicely. And I think we'll see something coming out in the upcoming months that will really begin to help in this area. I think the ninth recommendation on increasing recognition and funding for diagnostics, this was largely a recommendation towards advocacy. And I think that the 2023 WHA resolution on diagnostics was really the best outcome of that. I think it's had a lot of attention, and I think we're starting to see some of the impact from that already. So I think the advocacy area, we've had a lot of success. And then the 10th recommendation was to establish an international diagnostics alliance to support all of these. And this is going to be announced, I think, by WHO this week. Adriana and others have done an amazing amount of work at WHO to pull this together. This is really a group I think that's going to carry this forward over the upcoming decades. There's a lot of work left to do, but this will be a more concentrated effort to help move this along. It is of a lot of interest that when we were writing the original commission report, we had a day devoted to working with industry on some of their needs to help increase access to diagnostics. And it was fascinating that to a person, they said there needs to be some forum, some alliance, some place where they can interact with regulatory bodies and academia, WHO, funders to really do this. So I think that this is a tremendous opportunity that we'll all see over the upcoming years. Then in my last slide, just want to note that there were in the WHA resolution, the request of the Director General of WHO, the last three, we just wanted to emphasize that the task was, we liked the wording, was to avoid siloed guidance, policy, and funding streams. And then in the next one, also to avoid siloed programmatic and diagnostic services. And the idea was here that we need to take a more holistic approach to diagnostics in the future. That while we've had amazing success in some of the siloed programs, for HIV, TB, and malaria, the challenge has been trying to leverage those for other diseases and conditions, and particularly as we move into an area where we have to think more about non-communicable diseases. And so the idea in these three recommendations here for the Director General are that we begin to look at things in a more broader perspective and begin to leverage what the work we're doing in one area so it can be used in other areas. And really, this is going to require more of a systems approach to the way we approach diagnostics in the future. I think it's something that we just haven't done over the last 20 years because of the incredible needs we have for specific areas. But as we begin to move forward and as we see emerging new technology, there are some interesting approaches to using information technologies to really pull different diagnostics together, that we really need to take more of a systems approach to things and start to move away from what we've had to do, but start to move away from looking things through a siloed perspective. And again, just want to thank everyone for the opportunity to participate today, and please take a copy of the Lancet Commission update, read it, and share it with others. And thank you again.
Thank you, Dr. Michael Wilson of the Lancet Commission. Sabine in the room, and with that, the report is duly launched. Do please grab a copy, and everybody wave your report in the air. And with that, I'm ending this segment, the high-level segment of the meeting. But as I end the high-level segment of the meeting, I'm going to turn to the most important people in the room. We have spoken to ministers, we've spoken to leaders, but I have a very special group of friends in the room here today who are young people, young students who, some of them joined me last year, and you're back again this year. I would like you all to stand up and be recognized, because you are the future. You are today, but you are the future, and it's incredible that we have you here with us today. From a wide range of backgrounds and countries, medical students, my daughter from Georgetown, all of you here, thank you so much for being here. Thank you for being the bridge between your generation and ours. You are the generation who are going to fix everything that we broke. So no pressure, right? No pressure. But I hope you are learning. I hope you are thriving in this WHA. And thank you very much for being here. You are my VIP guests. Thank you. And without further ado, I'm going to hand over for the next session, which is going to be exciting. Several friends here for that. I'm going to leave it to somebody else to introduce them. I shall hop off the stage and you will not hear from me for a while. Thank you.
Okay. Thank you, Madam Chair, for very good moderation. And I think that was a very useful session as far as hearing from the political side about what can be done, or exemplars of what countries can do to advance the diagnostics agenda. We've not necessarily saved, next, we're going to the next session, which is not, I was just trying to say that it's not the last session because it's less important or because it's not interesting, but we think this is the best time, given all we needed to have had all the prior conversations before dealing with this. So this session is starting a bit late, but I'm sure that we will have excellent moderation. So the session is the next pandemic, what should happen before day one? As some of you may recall, I articulated the 100-day mission, and I did say that it assumes, even if it's not explicitly saying so, that a lot of the activities that, a lot of actions need to have been, to be taken before the next pandemic is declared. So to help us navigate this session, it's a pleasure to introduce Professor Vernon Lee of the Communicable Diseases Agency of Singapore. Vernon is, I've known in my previous life as when I was Director General of the Nigerian Center for Disease Control, and there is no better person to help speak about pandemic preparedness and response. So Vernon, welcome.
Thank you so much, and a very warm welcome to this last session. I'd like to thank, of course, my friends at FIND and all of our colleagues for this kind invitation to chair this panel. Oh, I think it's my iPad. Sorry, I'm less of a, as you can see, a pen and paper person, so I have to view my notes from from the corner of my eye now. Okay, anyways, I'll make this happen. Okay, where was I? Yep. So thank you once again for this kind invitation to chair this session. But we have a very stellar panel lined up for today to talk about the 100 Days mission, some of the gaps that we have found in evaluating this, and also what are the opportunities. Every time I see a crisis, a gap, I always think about opportunities, how we can do better, how we can build better, how we can strengthen our programs. And when we talk about the next pandemic, the topic today I thought is extremely pertinent. What should happen before day one? Because a lot of times we prepare for the next pandemic and then we wait for it to come. And then, of course, it is very important to work together during the pandemic itself, exchange information, collaborate in new technologies, including new diagnostic technologies, and utilization of these technologies as part of the 100 Days mission roadmap. But it takes 100 days. That's the aim to get to where we hope to be. However, what if we can do some of this work even before the next pandemic starts? What if we can start preparing ourselves ahead of time? We can actually reduce that 100 days to a lot shorter, and in the process, be able to detect diseases quicker, be able to prevent its spread where possible, or at least prevent its rapid spread, and reduce the impact to lives and livelihoods. I think that's something that we all really need to look forward to. So by working together right now in times of relative calm, we can actually accelerate this entire process. So this session aims to foster dialogue on diagnostic preparedness and partnership opportunities in times of relative peace, and present progress on the 100 Days Mission Diagnostic Roadmap, and also share on the Diagnostic Preparedness Gap Assessment results so that we can use those gaps and look for opportunities that we can work together now. So at the end of this session, I hope that you will be able to implement those strategies based on the lessons learned from recent events, including COVID-19 or Mpox, and ensure equitable access to diagnostics in all communities, especially in sort of lower resource settings during outbreaks and pandemics. But the time to prepare is now. It's not during the pandemic itself. So today we have two speakers. First, we have Dr. Agogo, who I understand is online from FIND. Yes, that's right. He told me he was online to to present on the 100 Days Diagnostic Mission and also introduce this gap analysis study. And subsequent to that, we also then have Kaya from IPPS who will be sharing about the actual gap assessment findings and key results. So maybe I'll turn the floor over to Dr. Emmanuel Agogo online. Yes, okay, we can see him on the screen over there.
Good afternoon, everyone. I don't have a slide deck to run through. Can you hear me okay?
Yes, give us a second. We can hear you, but we would like to see you as well.
Okay.
Perfect.
Right. So good afternoon, everyone, and welcome to the Diagnostics Day at the PPPR session. I don't really have a slide deck to give, just to say a few words, which just to reflect on some of the work that FIND has been doing around pandemic preparedness. The session that is about to follow is one where we're looking at the gap analysis of the 100-day missions roadmap for for the 100 missions roadmap for diagnostics. Essentially, as FIND, we've been working with IPPS and Brown University to look at all the bottlenecks that have been existing in terms of preparing for the next pandemic. And a few pieces of work we've done, which are on our website, and we will, it's in the, I think there's a 2-pager that kind of outlines all the work that we've been doing in PPPR, includes the Pathogen Diagnostic Readiness Index on our website, which tells you about the preparedness of diagnostics for 21 pathogens. And those pathogens include those in the WHO R&D blueprint, which of course we know now have been organized into the with the viral family approach. We really want this session to be very interactive. We have a very astute panel of speakers who will run us through some of the thinking around the finding, ranging from the issues around the R&D bits of diagnostics all the way to local manufacturing and financing. And without much ado, I'll pass it back to you, Vernon, so that we can invite Kaya to go through the slides. Thank you very much, and I wish I was there with you in the room. Have a great session.
Thank you so much, and thanks for spending the time with us, even though you can't travel to Geneva. I think the 100 Days Mission roadmap and also the gaps analysis, like I've mentioned, and as Emmanuel has mentioned, is extremely important to us to understand what are the issues that we're faced with, and so that we can address the issues and take it forward. So without much further ado, I would introduce our next speaker, Kaya Domenicus from IPPS, who will help to, I guess, explain to us the gaps analysis study and also the actual findings and what actually we can do with those findings to move forward. So thank you so much, Kaya. Take us. Thank you.
Yes, perfect. Great. Hi, everybody. Thank you so much for having me. My name is Kai Dominicus. I am the Technical Policy Officer at the International Pandemic Preparedness Secretariat. And for those that are maybe not completely familiar, IPPS is an independent secretariat that works with government, industry, and global health institutions to track and support the implementation of the 100-day mission, which Vernon very nicely outlined just now, so I won't go into more detail on that. I'm very excited to be here today to present some of the emerging findings from the gap assessment that we've been conducting in collaboration with the Pandemic Center at Brown University and with FIND. And before we jump in, I'll just give you a little bit of background to the 100-day mission for diagnostics. Next slide, please. So the 100-day mission for diagnostics has has 2 main goals. The first is to support a coordinated and sustainable diagnostics R&D ecosystem, and the second is the development of diagnostics libraries to provide broad coverage for priority viral families. Next slide, please. Right, so in order to achieve these goals, we wanted to build a stronger evidence base of the more granular challenges across the ecosystem, and this is what led us to decide to undertake the gap assessment. By having a clearer understanding of what those critical barriers are will enable us to work better with our multi-sectoral partners to address these gaps and to then also feed into existing initiatives to do so. So we've taken a case study approach, acknowledging that there are likely to be both cross-cutting issues as well as pathogen-specific barriers and recommendations. And for the case study selection, we focused on WHO high pandemic potential viral families, considering diagnostic needs, political public health context, and infectious disease market archetype. So we've examined 3 specific pathogens representing very distinct market archetypes. So the first is Ebola. This is an emerging and re-emerging infectious disease with low market potential and low volumes except during outbreaks. The second is dengue. This is an infectious disease with high burden predominating in low and middle income countries. And our final disease is H5N1 influenza. This is infectious disease with potential markets in both high and low and middle income settings, but has access and affordability issues in low and middle income countries. In this context, H5N1 also serves as our disease X prototype. So we've interviewed approximately 30 global stakeholders across industry, financing, and regulation, as well as international organizations, as you can see up on the slide here. And as output, we are producing a fairly concise report where we're really wanting to look at the end-to-end gaps across the ecosystem and also then provide very clear priority actions and recommendations for our stakeholders. And then, as I said, we will really endeavor to also work closely with our stakeholders in addressing these, as well as feeding into complementary initiatives such as the WHO Diagnostics Coalition. So today I'm going to be presenting a few preliminary findings from our analysis, as the analysis hasn't been fully completed yet. There are a couple of limitations that I would just like to caveat very quickly before we jump in. So everything that you're seeing here is coming out of a first interview phase that was very developer-centric. So we've not had much interaction with CSOs and end-user engagement, but this is something that we intend to be following up on for our second interview phase, which will be happening shortly. The second is that we are focusing on near and true point of care diagnostics for this analysis, and we've placed limited emphasis on surveillance systems. Next slide, please. So as I mentioned, I'm sorry also that I realize this slide is a bit overwhelming, but we'll get through it. So our analysis isn't fully completed. So again, these findings are preliminary. They're emerging insights with additional details and nuance to come out in our report, which I would encourage you all to read once it's been published. So looking at the diagnostics ecosystem, we've identified key barriers across several interconnected areas, and I'm not going to go into all of them in detail here, but we'll just run through kind of loosely. So for R&D evidence generation and regulatory authorization, these areas are obviously very interconnected. Many of the barriers and recommendations that came forward are all broadly applicable, but do require some pathogen-specific nuance. We don't need a completely market-specific approach here, but rather sufficient specificity when implementing solutions. Looking then at manufacturing, distribution, and procurement, differences here relate a lot more to company size and regional context than they do pathogen-specific nuance. And so the recommendations are more adjusted according to global or local manufacturers. In financing, we found that a pathogen market archetype approach was absolutely necessary. So each market presents very distinct financing challenges, and therefore the recommendations for those different scenarios need to be different financing mechanisms. So next slide, please. Thank you. So we can't really cover all of the emerging barriers in detail, but we have pulled out some of the key barriers and recommendations here for a bit of discussion. So I'll begin with the challenges and recommendations that span from R&D all the way through to regulatory. So the first barrier that consistently came out in our conversations were around limited access to samples and reference panels. So this is a really big issue, and it does have pathogen and region-specific nuance as well. So, for example, sample access, understandably, is particularly difficult for low volume or high containment pathogens like Ebola. Recommendations that came out of our discussions include developing common sample sharing protocols globally and regionally. So the PABS framework being negotiated will absolutely also need to incorporate a really broad stakeholder perspective, including that from industry, because this is something that can either really enable or be a hindrance to industry engagement. Separately, several stakeholders also have recommended forming dedicated consortia for independent evaluation and doing this through a network of core reference labs. and or accelerator programs to provide that centralized validation service to ensure test quality. So the second problem or the second barrier that came up quite a few times in our discussions was around siloed single pathogen test development. The issue here is that this is, it can be quite an unsustainable business model, and it limits routine clinical applicability. So the emerging recommendation here is to prioritize the development of multiplex syndromic panels that integrate both endemic and emerging pathogen detection into routine healthcare to increase that market viability, alongside also adaptable platforms that maintain diagnostic infrastructure but can pivot easily to outbreak scenarios when required. So on the regulatory front, fragmentation across jurisdictions creates really major inefficiencies and barriers to entry. So the recommendations here focus on developing common dossier templates and standardized evidence requirements, operationalizing regional regulatory bodies like the African Medicines Agency, and implementing practical reliance mechanisms between authorities. And we are already seeing some really encouraging things happening here with the IMDRF reliance playbook. Next slide, please. So next, for manufacturing, distribution, procurement, and surge capacity. So the most prominent barriers here, as I mentioned previously, differ between global and regional contexts. So for global manufacturers, market and volume predictability, it remains a really, really persistent challenge. So confidence in sufficient demand is understandably key to justify investments. And the recommendations to address this include investing in improved market intelligence and demand forecasting tools, as well as developing tailored market-specific pull incentives, but we'll touch on those a little bit more in our financing section. Then for regional manufacturers, the main barriers that came out of the analysis are a little bit different. So limited manufacturing capacity in low and middle income countries is a really foundational barrier to sustainable diagnostics access. Recommendations here include investing in regional R&D and manufacturing with adaptable technologies for both endemic and outbreak response, as well as establishing procurement systems that guarantee the demand for local products. And then in addition to that, it's incredibly important to also address those workforce skill shortages that need to feed into the systems. The second issue that came out for more regional manufacturers was that tech transfer is incredibly expensive, and it requires equitable partnerships in order to succeed. The recommendations here include dedicated funding and support for comprehensive tech transfer programs, including workforce training and quality systems development. And then finally, access to raw materials was a point that was raised by almost everyone in low and middle income countries that we spoke to. This remains really difficult for regional manufacturers. The recommendations here include investing in local critical raw material production to reduce imports, supporting backward integration for critical reagents where this is possible, and developing regional supply chains with local providers to strengthen that ecosystem resilience. Next slide, please. So as I mentioned at the beginning, in the finance discussions, this is really where the disease market archetype really came out of our analyses. So each market presents very distinct financing challenges, and they required tailored solutions. So for tests like Ebola, which occurs sporadically and largely in low and middle income countries, faces effectively a zero market scenario. So these are pathogens with unpredictable outbreaks, and they require really small volumes of tests with no real sustainable return on investment. And stockpiles for these tests will often expire unused, which effectively creates a fundamental market failure. So to overcome these barriers, the recommendations include a dedicated new effort to implement advanced market commitments and volume guarantees to provide that certainty despite that unpredictable demand, as well as developing blended finance instruments combining public, philanthropic, and commercial capital to distribute some of that risk. On the other hand, for high burden diseases that occur regularly in low and middle income countries like dengue, volume potential makes a market theoretically possible, but this is largely unrealized. So in the case of dengue, we observed that tests entering the market have a really high degree of variable quality. And there's also a limited ability for low and middle income countries to pay for these tests, even though they have a really high burden of disease. And that results in a really fragmented purchasing of tests across different regions. So to overcome some of these barriers, the recommendations that came out of the analysis included new financing mechanisms to create multi-country pooled procurement to aggregate that regional demand. And another point that really came forward is that the quality standards to support procurement of high-performing products is really essential as well. In the case of a disease X scenario, so in this case that constitutes our H5N1 as a prototype, there is a potential need for high but sporadic volume of testing in both high-income and low-income countries. But during emergencies, the competition between markets often results in really inequitable access in low and middle income countries and a really extreme supply diversion to higher income countries, as we saw very clearly during COVID. So in this scenario, the recommendations that came out included designing a financing model that would subsidize affordable access in low and middle income countries and paying manufacturers through more of an insurance-like model, which maintains some of that capacity during non-emergency periods. So across all three of these market archetypes, we found that funding for tests is really siloed with limited end-to-end coordination, and there's a real absence of surge financing mechanisms. So new financial mechanisms are absolutely needed to help manufacturers rapidly scale test production during outbreaks. For example, a working capital facility like the initiative being developed by the IFC at the World Bank could support regional test manufacturing and pilot surge capacity for different outbreak scenarios. And then looking across all of the challenges that we identified, we also see some opportunities to develop innovative financing solutions that might simultaneously address a number of these different barriers to accelerate that end-to-end diagnostics development. For example, public and private sector financing could come together to support regional diagnostic evaluation hubs that support developers with both sample access, evaluation, and regulatory support. And these hubs could then be linked to benchmarks that drive procurement of standards of a certain test quality, and thereby also de-risking some of that investment. Next slide, please. So I appreciate that was a really, really fast tour through our preliminary findings. We obviously really welcome your feedback on some of the emerging insights from the gap assessment. And please do read the report once it's finalized, because we would love your insight on the more final and full analyses as well. We will be holding a roundtable probably sometime in July, where we'll be discussing some of these findings in more detail, as well as next steps forwards. And we'd really welcome you to join in on that discussion. So if you are interested in that, please contact us on the email you have up on the screen, and we would love to add you to our list. And then just finally, we'd really like to thank you for all of your engagement and your commitment to helping us achieve the 100-day mission for diagnostics. And now look forward to diving into some of the discussion and hearing from all of you how we can work together on achieving some of these practical solutions. So thank you very much for your time.
Oh, it's my iPad again. Sometimes it's better to go into the the old school pen and paper. But thanks so much, Kaya, for that wonderful talk. I think she's given us a lot of thought-provoking issues on the gaps regarding the 100 Days mission, but also a lot of the opportunities that we can come together to try to address those gaps, including in research and development and evidence generation. And research, I want to emphasize, is key to developing products and also the policies to utilize them more effectively. Also regulatory approvals, which we need for the rapid implementation of these diagnostics. Manufacturing and distribution is the other thing that we need to look more at, not just global manufacturing, but also regional and local manufacturing platforms, and also distribution networks to bring them those diagnostics to where they're needed most. Surge capacity, because as usual in peacetime, our capacities are usually quite used to the maximum. So we have to see where actually to get surge capacity to actually be able to bring resources and also diagnostics to bear when we need them, and also novel financing solutions. We need to look at how best to obtain resources to support these. And I think earlier Pak Budi had given a very rousing presentation on how we can actually look for resources, because they are certainly out there. And also, how do we adapt these recommendations in the local context? So I think that is quite a good segue to the next segment, which is a panel discussion. And the panel discussion will be looking at how do we address some of the issues that we have just heard about. How do we deal with those bottlenecks in terms of incentives, regulations, infrastructure, and look for positive solutions at coming up with what we actually need to prepare for a future pandemic. Now, as for everything at the World Health Assembly, and like the COVID-19 pandemic, change is always a constant. I learned that in my experience dealing with the COVID-19 pandemic, and also in setting up the agency that I currently head, the Communicable Diseases Agency. We are probably the youngest national public health agency here at the WHA. We only formed the 1st April last month. So we... Yeah. Okay, so there's a newer agency, I've heard. Okay, but that is good, because I think a lot of the lessons that we had learned from the pandemic and from other crises had been used in a positive manner to develop new systems, and I hope likewise that that's the case for diagnostics as we move forward as well. So, as I'm quite familiar with changes, one change that I've been told is that Yukiko is not able to join us this afternoon. I believe that she was here earlier to share some of her thoughts on WHO's thinking about diagnostics. But of course, I have my old friend, Nadrat Imiroglu. I think Nadrat is here, and to replace Yukiko on the panel. So, without further ado, if I can invite my panelists up to the stage, where we can have the panel discussion, and where you can also engage the panel in asking any relevant questions. So I have Hugh Lun Fipo, Head of Secretariat of IPPS. Welcome. Yep, I have Nadrat, please, who's Director of Health Emergencies Core Capabilities. Nadrat, if you can, is Nadrat here? Oh, it's not here yet? Okay. I was told that it's another change, but don't worry, we'll deal with it. Maybe he'll come later. Javier Marcos, Head of the AMR and Veterinary Products Department of World Organization for Animal Health. Welcome. Dr. Thomas Chuani, he's of course an old friend of ours, a former Director General of IFPMA, who needs no introduction. Of course, Dr. Mario Moreira, who is the CEO of Fiocruz in Brazil, another leader in this field who again needs no introduction. And finally, Joanna Sickler, who is Head of Diagnostics Health Policy in Roche. So we have a very distinguished panel who will be able to address many of the various issues that we have brought up today. So maybe I'll start first with Hyun. Based on the challenges identified in the 100 Days Mission Diagnostic Gap Assessment, how can stakeholders work collaboratively to address them in step with other activities for vaccines and therapeutics? And what are some of the potential roadblocks in your mind, and how we can address them? Thank you.
Thank you. Can you hear me? Great. Hi, it's so wonderful to be here. Diagnostics Day is always a highlight of WHO for me, because I'm a huge fan of diagnostics and think they can often be forgotten. So thank you to FIND for bringing us all together today. I won't repeat the brilliant analysis that Kaya has shared of some of the challenges, but like you, Vernon, I think for every challenge, there is an opportunity. And my friend Christiana enlightened me to the fact that in Chinese, the word for crisis is weiji, which apparently means both danger and opportunity, which I just think is amazing. And interestingly timed, I've just seen that they have offered to donate $500 million to WHO, which is an interesting opportunity. Congratulations, our Chinese colleagues. But yeah, to your point of how can we organize ourselves around addressing some of these challenges and finding solutions. The 100 Days Mission is all about kind of challenging ourselves to do things differently by having such an ambitious goal that it forces us to think in new ways about how we can respond to that challenge. And so I just want to share a couple of suggestions around areas that we could coordinate around to do things differently, to force us to collaborate more closely. And I'm really looking forward to what the other panelists have to say on this topic as well. I think, firstly, we need to acknowledge that we need equity of investment across all three tools in vaccines, therapeutics, and diagnostics. And currently, we are not there. In 2023, $13 million were invested in diagnostics compared to $158 million in vaccines. That does not mean we should invest less in vaccines. It means that we should increase and reach equity across the board in all three medical countermeasures. And we need to advocate for the need for all three tools working in harmony as part of every outbreak response. Every national government should have the right to have access to all three tools to protect their populations. We're very familiar with the role of vaccines. We're sometimes less familiar with advocating for the role of therapeutics and diagnostics, but therapeutics play a critical role in that period when we may not have a vaccine, or for the people who cannot or will not take a vaccine. And diagnostics are the light, the torch in the darkness when we don't know what we're dealing with. And we absolutely need rapid point of care diagnostics that can help us to find our way in those early days. But just a few areas that I want to highlight that I think we could work together more closely on. So yes, we need equity of investment across all three tools, but we also need to be smarter about the way that we use those limited resources and to think about the synergies across diagnostics, therapeutics, and vaccines. Can we think about bringing together packages of products? It's one of the reasons why I'm so excited about the corks, and which Mario may talk about later, as Fiocruz heads the flavivirus cork. If we can be looking at diagnostics, therapeutics, and vaccines for the flavivirus pathogens collectively, there are synergies and efficiencies that we can make there. We can think about diagnostics that enable more rapid enrollment in clinical trials. We can think about test-to-treat programs. We also need to be encouraging our procurement partners to be thinking about the incentives they can send to send market demand signals that they want to procure packages of vaccines, therapeutics, and diagnostics collectively. So that's one thing, the synergies across vaccines, therapeutics, and diagnostics. Secondly, I think we need to think about how we can ensure that any solutions for pandemics and outbreaks can also be embedded in routine care systems in interpandemic periods. So how can we think about, as well as needing our rapid point of care single pathogen tests, how can we think about making more of multimodal multiplex diagnostics that can be able to detect both endemic and potential pandemic pathogens, such as multiplex panels that can look at seasonal flu as well as pandemic flu, or within flaviviruses that can look at dengue as well as Zika, etc. So I think that really does force us to think differently, because I think we need to think differently about the target product profiles for those multiplex tests to make sure that they're still affordable and accessible and usable in communities. We need to think differently about the regulatory pathways for multiplex, because I think my regulatory colleagues tell me it's very complicated and changes the risk-benefit profiles, but we have to be able to find a way on that. And again, we need the demand signals and our procurers and investors to be sending the signal that they want to invest in those multiplex technologies. And then linking to that, regulation, which was brought up as a challenge, but has to be an opportunity. From everything colleagues, again, in the regulatory space tell me, we are much further behind on harmonization of diagnostics regulatory pathways than we are for vaccines and therapeutics. I would actually say that the African Medicines Agency is an exception to that. They are building in from the ground level ways of having better medical devices, harmonized approaches. But I think for the rest of the world, we need to learn from that and think about how can we support some of the efforts that WHO is starting in Rogerio's team to try and have more mature medical device regulators around the world, but to ensure that there are mutual reliance mechanisms for diagnostics regulation. And I just think that is one area that we can and therefore have to try and do something about. I think we should support the work of the IMDRF, which is the forum where medical device regulators come together. They are developing a playbook to try and look at harmonization of devices regulation. I think there is an opportunity with the new WHO Diagnostics Alliance that could set a normative function to bring regulators together. And at the roundtable that Kaya mentioned we're hosting in July, we want to put a focus on, can we take a case study of a particular pathogen or a particular viral family and look at what would it take to have harmonized dossiers to bring regulators and developers together to think about how can we simplify this process for developers to make regulatory approval of diagnostics still safe, still rapid, but how can we make it a simpler process so there isn't a disincentive to innovators to be getting into this space. And lastly, you asked me to think what are bottlenecks to us working in this way and collaborating on those new areas. And I think often a bottleneck to collaboration on challenges is just it's too hard or it's too complicated. And I think there is a lot of complexity in this space, but these people on this panel are all experts at dealing with complexity. And in my mind, I think we just need to agree the goals. We need a shared framework to work underneath. We have this canopy of the pandemic agreement now. We've got this potential framework of the WHO Diagnostics Alliance. And in the epidemic and pandemic space, we have the 100-day mission diagnostics roadmap. I would love to see us all agreeing these are the building blocks of diagnostic preparedness we want to work towards. This is what a particular sector or a particular organization is willing to put their hand up and commit to, and then we all run as fast as we can towards those goals. So that would be my challenge to us today. Thank you.
Well, thank you. And you have mentioned many things that really resonates, I think, with many people in this room. Certainly resonates with myself on some of the potential solutions, but also how do we tackle the roadblocks. And I like the part about simplifying things because I think our world is already too complex. So we need to keep things simple. So maybe next I'll turn the floor over to Javier from WOA. And we know the One Health approach is extremely important. We need to work together across agencies, across sectors. So what is perhaps missing regarding the One Health approach in diagnostics, and what innovative diagnostic approaches are vital for monitoring zoonotic outbreaks, and how do we come together as a One Health community to address those? Thanks.
Okay, thank you very much. First of all, I would like sincerely to thank Find for inviting an animal to the room. So thank you very much for incorporating this part to the equation. And then second, it's a pleasure to be here because I spent 18 years of my career working in human diagnostics. So somehow it's like coming back home. So to your question, I think that what we are missing in the One Health space is what the audience is missing. Thank you for staying so late. It's a cup of tea. Let me walk you through it. The first thing is that what we need in this space is communication. What we need is cross-sectorial mechanisms at the governmental level where the ministries of health, agriculture, and environment are talking together. We know that today we have AMR, antimicrobial resistance, as a growing problem. And if you follow the news, last year there was a resolution from the United Nations where they were providing a series of commitments, and one of those commitments was for the countries to create these cross-sectorial mechanisms where the different sectors can talk together. Then the second aspect that we need around this cup of tea is the transparency and the trust. So we need to work together and we need to build this trust, and this trust is built based on transparency and sharing data. You might remember what happened when COVID appeared and the data were not shared, where this is coming from, etc., etc. And I think humanity or mankind would have moved much faster if we had these cross-sectorial mechanisms talking together and sharing the data and the information. And the third part of this cup of tea is the education. It's not only education within governments, alliances, or networks, it's also education of the young people. And I'm very pleased to see here that we have some representatives from the future, so that you can be aware that without talking to each other and understanding the limitations and the strengths of the others, we cannot fight, we cannot win this fight. And then the last part of the equation is the A. So it's just to be aware. First thing is a double A. The first A is just to be aware that being preventive is much cheaper than being prepared. So I'm sorry for all those who are working on preparedness, but I wanted to say that I wanted to remind you that the World Bank published a very interesting report in 2022, which is called Put Pandemics Behind Us. And if you look at the 4 pillars of how to put pandemic behind us, they were saying that first, that working on preventative measures, prevention, was half cheaper than working on preparedness. And among these 4 pillars, they were saying that one was strengthening the animal health systems and the veterinary services, because we need workforces to detect and to screen what is going on. And one of the other pillars was improving the on-farm biosecurity. Because you have to know, and you have to be also aware that 3 out of 4 of the pandemics that we have lived in the humanity are coming from animals. So having this surveillance around, it's essential to prevent the next pandemic from happening. And then finally, is the double A is to accept that we are not alone in this world. And even if I'm the only animal in the room, you are all animals here, and we are one of the other thousands of animal species that we have in the planet. And we are sharing the environment, we are sharing pathogens, and we all have to be aware and respect every ecosystem. So that's what is missing in the One Health space. And on the innovation part, very briefly, it's basically what it has been said and presented during all this conference. We need technological innovation, genomics, metagenomics, wastewater surveillance, point of care to have faster detection at the farm level. We also need regulation, innovation in regulation. The regulation in the veterinary sector is much more fragmented than in the human sector and is not at all harmonized. So just for you to know that there are out there 3,000 diagnostic kits for animal diseases, and the regulatory control is absent. So we also need innovation in the economical ecosystem, as the same difficulties that the human sector is facing with diagnostics to make it profitable, health economic ecosystems, etc., is happening in the animal sector. And last but not least, we need this human innovation, which is going to the cup of tea. And around the cup of tea is where we have conversations, where we create trust, when we get educated and we educate others, as well as we become aware of things that we didn't know, and we accept reality and realities that we need to work together. Thank you.
Well, thank you. Tea, yes, indeed. You know, a cup of tea, something that we all have, and it's a good opportunity for us to sort of come together and collaborate. I think that's the main thing. And you even made a nice acronym out of tea. I need to start inventing acronyms for coffee, beer, and wine as well, but next time. But I think that's a really good sort of a point you made about the need to innovate. And by innovate, it's not about doing things the same, just sort of small improvements, but by thinking out of the box, by looking at disruptive technologies and what we can do in a different way. So maybe that's a good segue to the next panelist, Mario from Fiocruz. So obviously you are a very large regional producer of diagnostics and a leader in this field. What are some of Fiocruz's perspectives on the challenges and opportunities for innovation and production, and how are these aligned with the new pandemic agreement that was just passed yesterday? Thank you.
Okay, thank you. First of all, I would like to thank you for the invitation. Okay, and I'm very proud to be here in this panel as the global health representative of the diagnostic sector. Okay, and I do believe that I can contribute to this discussion, bring a very singular experience about the Oswaldo Cruz Foundation. As you may know, Oswaldo Cruz Foundation is a state-owned organization, non-profit organization that develops several activities related to public health, education, surveillance, hospitals. We have 2 hospitals, but we are also a big manufacturer. We produce their vaccines, diagnostics, biodrugs, medicines in the industrial basis. But we are also embedded in a very consolidated public health system, a public universal, that demands a lot. Services and products. We are 200 million Brazilians there. And in Brazil, health is a matter of constitution. It's a right of the citizens and the obligation of the state. So this is the configuration, the scenario where Fiocruz play its activities. So we must believe that we must make available all products the Brazilian population needs. So the second point is, I was reading that together we can ensure that everyone needs a test can get one. And you have to celebrate the pandemic agreement approval because it's about that. It's about that we are discussing, about equity in the aspects of health in general. And in terms of diagnostic, even from vaccines and medicines, aspects is not the possibility to buy or possibility to receive as a donation. It's much more than that. It's about it to have a very well-established public health system to deliver this to the population, to have physicians, to prescribe. There are a lot of things beyond the capacity to have the products. We believe on that. Another point I would like to bring is Fiocruz started to produce vaccines since the beginning of the last century, but diagnostic not. It was a very, very new activity for us. We started this serious about the 19th, about the time that the HIV epidemic came from the whole world. So we started to produce diagnostic in that time. And to do that in GMP condition, industrial scale, we had help from private companies to tech transfer. First, rapid test diagnostic is technology with American company. So we started to produce HIV rapid testing, 1 million and a half per year at that time. And just after that, we had another tech transfer agreement. We started the production of molecular tests as well to control blood donation, because that was very, very important to avoid contamination through. So we start to produce also HIV, HCV tests. Now this test is much more complex. We produce also HIV, HCV, HBV, and also malaria in the same test. And also we organize a national labs to do that in high scale. We have 3.5 million of donations per year, and we control every bags using Fiocruz test. After that, I would say that the learning process, how to produce tests, and most important, how to develop tests, allowed Fiocruz to have nowadays 55 different tests in our portfolio, delivering to national health system for different programs, HIV, child health, a lot of different programs. It doesn't matter. But most important also is, beside that, we now are a big producer of diagnostic tests. We are prepared to respond to emergency situations. So just to provide an idea, during the COVID pandemic, we jumped from 1 million molecular tests per year to 18 million. 18 million. And rapid tests from 4 million tests per year to 8 million tests to supply the Brazilian needs at that time. Besides that, we organized also a big centrals, high throughput centers along the Brazil to have the capacity to test as well, because we were delivering a lot of tests, but the states didn't have the capacity to test, so we assumed this. And as a result of everything, we started to test how could we transfer our technology for countries in in Global South. We started with Mozambique. We had a very nice experience with them, developing together a molecular test to detect malaria. At that time, it was an agreement among National Institute of Health of Mozambique, American CDC, and Fiocruz. And within 6 months, we had a new malaria test, molecular test, and also a team very well skilled to produce, to develop tests in Mozambique. Today, before I came to here, I checked with Mozambique Minister of Health. He told me they are there, they are produced, they are developing in-house tests, but they are there. They have capacity, they have capabilities to develop and also to produce and also to test for sure. That's why we talk about. You are now starting a cooperation with Senegal to do the same, but Senegal is a little bit better situation because they have already a lab. They organized a biomolecular lab there, but they don't know how to do this in GMP and also industrial scale. So we are signing agreements and the whole set of papers we have to sign before starting this cooperation. But we do believe that within a couple of months, they will start their production there. And they will get some time to have local certifications. What I'm talking about that, because I do believe this is possible. And also I do believe, I forgot to mention, that the Aztecs in worldwide scenario cannot work without local production. Of course, I cannot suggest here that every country must produce their own needs, to address their own needs, their own demand. But you have to consider that in terms of regional contest, we could think about that because it's totally feasible, totally feasible. Of course, I saw here in the presentation before, a very nice presentation, very, very nice presentation. I'll take this as a guide because I'm involved in this in Latin America with an initiative of Pan American Health Organization. They are mapping local conditions to have local production. And if you find allowed me, I will use this as a part of our methodology to do that. And I saw that tech transfer is expensive and must be done in very cooperative base. Because it's hard to private companies to do that. I know. I have agreements with the most important pharmaceutical companies around the world. Even with Roche, I have cooperation, Roche, Glaxo, Sanofi. It's another perspective. But again, Fiocruz is a non-profit company, a owner-stated company, and you have to work in this dimension, to collaborative and based in solidarity, based in we are looking for a global health. That's this I would like to try to you, and please, you can count on Fiocruz, okay, to spread the technology that we can, to learn with other countries, because we do believe that we must cooperate more. Thanks.
Some very good examples of the need for cooperation and collaboration, but also how you have provided assistance and we share best practices, and you also share your knowledge with others. I think that's certainly the way we can collectively move forward. So this is a good juncture to ask Thomas next. What are the mechanisms currently in place to support resourcing of ongoing preparedness efforts, and also for surge financing in the event of an outbreak? So what are the current resources and also potential for surge financing, especially in lower resource settings?
Vernon, I think the truth is they're still under construction. And I have to start with a couple of anecdotes in terms of where problems are. When I first met Dr. Alakija, now my friend Yodi was at the CEPI replenishment conference in London at the Science Museum, where everybody had to go through a PCR test to prove that they could mingle. Sometime later, I learned from my friend Richard Hatchett that half of the CEPI leadership team, who had been at the same conference as Yodi and I was, went to a retreat and was tested with COVID. So much, let's say, for high-quality tests in the UK. And I've had a early meeting with one of my friends from the pharmaceutical industry. Oh my God, he was really agitated about poor quality tests of the CDC. But in terms of financing, I also, we are confronted with challenges which we have to turn into opportunities. We had early in 21 a virtual exchange with a leader of a big European country who surprised all of us with full praise to the US taxpayer. He said, we wouldn't be where we are if the US hadn't banked us. Now, in terms of financing, and I do believe in terms of opportunities, it is important what I learned when we once analyzed lessons learned. There is a difference between vaccines, diagnostics, and therapeutics. For example, in vaccines, about half of the de-risking and scaling up of manufacturing, at least for many companies, was done by advanced purchase agreements or at-risk investments from countries, not least the US. Pfizer was the exception, because Pfizer, advanced purchase agreements, once you knew that there would be a vaccine, that's not, subsidy, but that's really making sure that you get it, but the others not yet. That's exactly what the pandemic agreement, I think, wants to avoid. I also believe in terms of when we look at it, on the way to Geneva this morning, I read a few of the articles from a guy I became friend with during the pandemic, Ruchir Agarwal. And I can really recommend that you have a look. He wrote the best papers, co-authored with Gina Gopinath from the IMF, on the rationale for financing. The rationale for financing is namely the cost of the pandemic, not the relative tiny cost of the vaccines or the tests, but the cost of the pandemic by IMF was calculated at $13 trillion, which, if I don't get it wrong, was $13,000 billion. That's a huge economic loss. Now, that's why, with all due respect, Heumann, in terms of, I'm a little bit agnostic or apprehensive of asking for too much upfront money. You can waste a lot of money if you have a lot of money. I also believe when we look at the science side of it, the best book, I'm now a happy retiree, as a number of you know, I read last year by far, and I recommend it as a must read to everyone, was Breaking Through by Katalin Karikó. When you read how this poor Hungarian woman who made it into a US university was mobbed, badly treated, neglected, and sacked for you are not up to the quality of the University of Pennsylvania, 10 years after she had done the path-breaking work on mRNA, which gave her the Nobel Award in medicine in 2023. It's really, I think we need to look into challenging how our universities in the most academically advanced countries, how they allow serendipity, how they allow perseverance. And that's not a question of just money, but it's a question of encouraging people to think out of the box, people to try again. And one of my peers in the industry I still respect most said, I actually occasionally run a cocktail party with scientists to celebrate their failures. I think, Joanna, you know whom I mean. And I had an opportunity recently for lunch, and I said, one of your predecessors told me we waste 50% of our research money. If I only knew which ones, and the response was, what, 50? Much more. And that's, I think, when I look into the financing needs, and Jodi, you and I were recently had a discussion, we really need to think ahead of the curve. Therefore, what Japan, for example, did getting out of TB crisis, UHC. And it's not manna from heaven. The countries like those, more than 50 from the Abuja Declaration, which 25 years later still are not where they should be, the countries need to get their act together. You organized a conference from Port to Arms. The issue of the syringes, the needles, the healthcare workers, that needs to be done country by country. That's why I think the downsizing of WHO is not just a curse, it could also be a blessing. And at the same time, I think all of us who care about solidarity, about global health, we need to shout out to make sure that people realize prevention and preparedness is important. And my apologies, with that I will end. I will never forget in Berlin, G20 or Hamburg it was, the ministers of agriculture agreed to ban use of antibiotics for growth stimulation in industrial livestock production. It lasted exactly a year until the same ministers of agriculture met in Argentina, and there was a, not to be named, coalition of Argentina, Brazil, and the US, of course, who agreed, oh my God, we never wanted to agree to that. That's why in Montevideo at the NCD conference where Dr. Tedros, hosted this big level, I caused a stir because I said, my precautionary principle on AMR is I stopped eating chicken years ago.
Thank you so much, Thomas, as always, and for your always very insightful thoughts and wonderful examples. I think one of the key points that that really resonated with me is the need to spend our money wisely. So getting money is one thing, but how best to use it, because you can get money and waste it on the other end. I think that's something we need to look at. So last but not least, if I can turn the floor over to Joanna. Roche is obviously a very large manufacturer of diagnostics. What will it take to pivot towards a multimodal, multi-pathogen diagnostic strategy aligned with the 100-day mission goals? That's the, I guess, silver bullet, holy grail that we all want. But considering the requirements for technological development, funding, and regulatory pathways to get to that endpoint. Thanks.
Absolutely, and it's a pleasure to share the stage with this group. Thank you so much for the invitation. I'm going to use a word that I've been hearing a lot this week, and a word that actually makes me very happy: integration. And I want to talk about integration through two lenses. The first lens is what a resilient lab system looks like. And a resilient lab system is point of care, it's high throughput, it's sequencing, and it's connected. And we need to be building resilient lab systems that have these capabilities. That's the first thing. The second thing is moving out of siloed approaches where we try to target one problem. Like, I think we all know we don't need an HIV lab, a TB lab, and now we have, a separate thing to think about pandemic preparedness. This all needs to be the same thing. And if we invest in a resilient integrated lab system that enables, to the point, care today, because in this environment, no government wants to pay for something they might need tomorrow. That's another problem, right? This is about care today, how we improve care, how we build strong primary care. I completely agree that prevention is very helpful. If we want to have good prevention, if we want to have good early detection, we need to have diagnostics connected to primary care. And so all of these things need to happen, including prioritization of diagnostics within health systems, because we had this sort of, it's so hard to say positive because the pandemic was horrible, but there was at least some recognition on the value of diagnostics that came out of it, which unfortunately I think is starting to fade away. So I also think keeping that focus within national planning, governments, about the role of diagnostics and how access to diagnostics is going to enable us to lower costs. Something I see so much in high-income health systems is an inability to actually think through the lens of, if I spend a little bit more here, I can save way much more money here. I think there are a lot of opportunities in health systems that are building up to be smarter about these issues and think early about how they invest in that prevention. I think doing that then enables the technological development. It creates the access pathways for all of those things to come in, because it's not just about one problem, right? It's about the entire healthcare system and the health of the population. I also think regulatory pathways and reliance and a lot of the things that were highlighted by IPPS are very important, and how regulatory institutions can rely on each other so that they're enabling rapid access to safe diagnostics, right? Because that should be the goal of regulatory systems, to make sure the right things are getting to the patients at the right time. And so I think if we can start to sort of bring all of this together and really focus on building those resilient lab systems, we can both be prepared, but maybe we will actually end up with some prevention.
Yep, thank you so much for those thoughts. I think it's very important for us to, I guess, again, work together and try to share best ideas and best practices so that we can get towards the same goal, same objective. So do we have like maybe 5 minutes for the audience to give some thoughts and maybe some questions? So 5 minutes, I know we're running a little bit behind, so maybe 5 minutes and then we can wrap up because we have some additional sessions after this. So anyone from the audience would like to ask a question? Yes, please.
Well, thank you very much, everybody. My question is for you, Javier, because I'm responsible for you being the only animal on the panel. Do you, so in the context of the next pandemic potentially being a spillover event from a zoonotic pathogen, or even in the context of One Health, are there priority pathogens that you think that perhaps there should be synergistic action between human and animal health experts in terms of developing or addressing developing diagnostics or addressing diagnostic gaps?
Yes, and I think WHO has already created a list of potential pandemic pathogens, and I think those are the ones that we need to survey, to watch. But in addition to that, I know that some coalitions or networks are there like hunting or chasing or watching the environment and seeing other unknowns, the ones that we do not know and that might jump over. I think what is missing in that piece is in those networks is at least one or two, I would say 20% of the laboratories part of this network. They should be fully animal health laboratories, because those are the ones who are taking care about animal diseases, the one for which we have no idea if they are going to jump into humans or not. It's not a big investment. It's just 1 out of 5 laboratories there. For every network, even for FIND, I was asking during the break, do you have any animal health company within the partnership, etc.? I mean, it's just adding 1 or 2, and as I said, communicate, learn from each other, collaborate, learn, because we know the most likely ones, but maybe there is something else that is going to jump and we do not know. And the animal health sector, if it's strengthened and if we have the capacities to do this surveillance, we can see it before it's jumping, or at least a little before it's jumping.
And question and also for the response. I understand that this room is actually needed for another function. So what we can do, if you have any other questions or comments, or you want to interact with the panel, we can do so at tea outside. Or if there isn't tea outside, you can buy them tea. So can we put our hands together to thank all of our panelists for spending the time together with us? Yep, so thank you so much. Just a couple of things just to sort of close this session. Okay. We want a picture? Should we join in the picture? Okay. Thank you so much. So we have heard a lot about the gaps today. We have also heard about the potential solutions. some of the key messages we can take home today, including simplifying processes, having a cup of tea, harmonizing regulatory pathways, and helping each other. And I think the outcome that we want is for everyone who needs a test to be able to get it. So finally, after talking about all the gaps and solutions, what we need next, oh, no worries. Yeah, okay. So essentially, just a final parting comment. After hearing about all the gaps and solutions, which are not repeat for the interest of time, what we need next is in the doing. So we need to get out there and get these solutions done. And the best way to do anything is to do it together. So with that, I'll leave you and I'll turn the floor back over to Yuri for the closing. Thank you.
Well, what a day. And unfortunately, Mario just walked out because we were going to sing happy birthday to him. Fiocruz turned 125, not Mario. He'd be doing well for 125. But Fiocruz turned 125, which is just incredible for an organization from the Global South and that is leading a lot of work in the Global South. I had the privilege of being at that celebration with their minister and very many others yesterday, and it was truly incredible to hear about the journey, to hear about the work that they have done. So I want to congratulate them on that, even in absentia. What a day. What an incredible day. I want to start off by acknowledging that it has been incredible amounts of hard work across the team. Just congratulate the CEO, the team, all of you. Dorcas, where are you? Dorcas, Beatrice, everybody, the entire team, just an incredible amount of work to put this together, and I want to acknowledge that first. We say in Yoruba, Orimiwu. As I watched this morning, I was unable to be here for the opening sessions, but as I watched this morning, my heart was, Orimiwu literally means my head was filled, but my heart was full. And it was standing room only in here, and we had some incredible speakers. And we started really where we should always start. We started with community, we started with people affected, and those who have not had access to diagnostics. We heard from an incredible man who talked about diabetes, something he said that struck me about so many children who die without even being diagnosed. I mean, that for me was just, it was jarring. We heard from civil society. We dived into local manufacturing. We've heard more about local manufacturing in this later session. We've talked about today how we can advocate for financing and the urgent need for financing. We've heard that we need to center women in diagnostics and in health more broadly. We need to involve more women. We need to support women. We need to ensure that we listen to women, that they're heard when they show up at the clinic, that we believe their symptoms. We don't just dismiss it as some, oh my goodness, oh no, it's your period, dear, or oh no, maybe, you're menopausal or something. We need to actually listen to women, and we need to, one of the examples I have is during COVID as I led the ACT Accelerator. It was unbelievable to me that nobody had done any trials with the vaccines with women. Did you know that? In 2020, 2021, there were no trials initially done on pregnant and lactating mothers. Women are too far out of this equation. So we heard from women, we heard about women, and perhaps also talking about raising the general understanding and awareness of the global public about diagnostics. For me, as a chair of this incredible organization, I have seen a rebirth. I've seen a process of transformation, and I've seen a rebirth. For those who remember, and I don't think there are many in this room who would, my very first board meeting 2 years ago, I told the board and I told those present that we would be entering a period of transition. We didn't know what was coming, but I felt we were entering a period of transition. And I said transition is often painful. Anybody who has given birth will remember and will understand, or maybe we don't remember, that's why we have more babies. I remember I only have one. But I said at that meeting that transition, especially in childbirth, is a time of great confusion, a time of darkness, a time where you just don't know whether you're up or you're down, what you're doing. Where I remember wanting to have a birth pool, and then I got out of the pool and I was like, no, I don't want to do that. Then I wanted to squat. No, I don't want to do that. It's a time of confusion. It's a time of darkness. It's a time of great pain. But at the end of it, oh boy, joy. Oh boy, we pray and hope for joy. And that is what I want to congratulate all of you at Find who have worked over the last year to come through that darkness into the light and into the joy. And as we work with our colleagues from the rest of the global health agencies who are entering into their own darkness, because we were the sort of trailblazers, that you walk hand in hand with them, those in the global health campus, those within the Geneva ecosystem, the lessons that you have learned, CEO, the lessons that you have forged, the conversations that you have had that many others are going to need to start having in the next few months. You are the ones that they will come to for lessons learned. So the global health landscape is undergoing profound change. The traditional models of cooperation and delivery are no longer sufficient. And we're living in a time where threats to health, whether from pandemics, antimicrobial resistance, misinformation, disinformation, or the growing burden of non-communicable diseases, are increasingly complex, interconnected, and global. And yet we must also center ourselves on the local. We must center ourselves in the communities where we work. We must remember that we are here for people, for individuals. It's not about the big numbers. It is about, we consider the big numbers, but it's about the individual. It is about that woman who's carrying a bottle of water on her head and can't get to a community health center, and yet she's in pain and her child has a fever. Can she get an RDT? Can we get down to that 300,000 from Indonesia that Pabudi talked about? Institutions like us must not only adapt to the new reality, we must shape it. So I'm proud to lead a group of planet shapers and planet shakers. We are shaking this world of global health, and we have a responsibility to lead the way in advancing a new model of global cooperation, one that is sustainable, one that is equitable, and one that is resilient. I have recently engaged with a number of country representatives. I've been warmly welcomed in Singapore, and thank you so much, Professor Vernon Lee, and thank you to your minister, my dear friend, my dear brother, my regards to him. I've been warmly welcomed by the Egyptians, by Pabudi in Indonesia recently, by the Kingdom of Saudi Arabia. We're all saying the same thing. The world needs to shift and change. We need to get more bang for our buck. And it's not so much that there isn't that much of the buck around. It's just that it's been in the wrong places. We need to call for diagnostics innovation and diagnostics to be funded from these communities where it is needed the most. So we are now also, and the CEO and his team are engaging with Africa Union, with African ambassadors and African ministers, and telling them we need you to come to the table. Because technology transfer is not just about transferring technology. Money also must change hands. I talk a lot about power changing hands, money changing hands, money coming from, the high-income countries. Yes, some countries have walked away from the table. They have abdicated responsibility for global health. Nature abhors a vacuum. It is time for some of us to step in to that vacuum and to take hold of the narrative. He who controls the narrative controls the power. I quote Daniela Lakija, my daughter, who knew that at the age of 28 I would be quoting a little girl, but she said the other day, he who controls the narrative controls the power. It is time for that narrative to shift, and I disagree when somebody said earlier that we shouldn't de-emphasize vaccines. I think we should actually de-emphasize vaccines. I think there is too much conversation about vaccines. I think there is so much now being said about the fact that, the whole anti-vaxxer movement is moving health away from health into sickness because we're focused on vaccines. And yet, if only we would invest in diagnostics, which would get us more bang for our buck, which would get the communities being healthy. We wouldn't need ministers of sickness. We would then have ministers of health. Look, it is my incredible and utmost pleasure to close this wonderful day out again by thanking all of you who have taken time to be here. Many of you have been here all day. Some have been online all day. I want to thank every single person who has contributed by conversations around tea. Where's my animal friend? By conversations around tea or coffee outside, on the podiums, in writing documents. The Lancet Commission want to thank you so much for launching with us tonight. We at FIND have led diagnostics. We led diagnostics through COVID. It was COVID that brought me to FIND. Some of the tests that you all used were done, and a lot of the research on them done and trials done through FIND. FIND is here to stay. FIND is growing. FIND is leading. FIND is leading a global transformation in the way, and we're leading in changing the way that global health looks. I make no apologies for it. I'm unapologetic in being a rebel. I'm unapologetic in saying that we are going to shake this world because this world needs shaking. We need to serve the communities that we were created to serve, and that is what we are going to do. Thank you very much, everybody. Welcome to Diagnostics Day. We'll see you next year.